Cochrane, who had what was between his ears, the training that he'd had, and he toted around this Gladstone bag, which was filled with those tools. I'm glad I wasn't born in that era, because those tools scare the bejesus out of me. I'm glad to have been born into what is a modern healthcare system of today, but it is very complex. It's a complex system. I guess you could divide it into three parts: prevention, diagnosis and treatment. And I like what Fritjof Capra has got to say about it. The most complex problems require the most holistic solutions. And I think that's true of a system that's composed of so many moving parts and so many interconnects. 41 health specialties, all of these ologies: oncology, immunology, hematology, and so on and so forth. So the system really is complicated. In the 21st century, we start with this, the development of human resources, not to be underestimated. In order to get your doctors, physicians and nurses, you need to train them. And so we use universities, teaching and research universities. The research is important as well. For that, you need the professors. So there are three here. Without the professors, you don't have the doctors. When I went through university, it was essentially free in New Zealand. You had to pay a nominal a fee at the beginning of the year, and then most other things were paid for. So we were, as a society, paying for the development of human resource. It was an investment. I consider it an investment. Today, universities have been turned into profit centres, and that has all sorts of consequences for us. We have insufficient doctors in New Zealand today. You also need physical resources, so that requires things like hospitals, imaging equipment. There's all manner of scanners these days, using X-rays, ultrasound and whatnot. And that enables us to see into the body with some pretty good resolution these days, and the resolution is improving all the time. And of course you need pathology laboratories. There you do the blood chemistry, you identify bugs and see how sensitive they are to various pharmaceuticals that we have. And you need some consumables. Pharmaceuticals and other things. All of these things, including the human resource, require complex supply chains. So I'll just assert that our health system has been failing for decades, and it's currently in a full-blown crisis. And the possible causes, the ones that are most talked about, are things like chronic underfunding, privatisation, which is a tendency to siphon off resources, and mismanagement. Always you can have mismanagement, and that implies sort of misallocation of resources. I would assert that 3 is relatively easy to fix, but 1 and 2 are a bit of a problem. How do we know there's a crisis? Now, Grey Power Federation has put this to me, and I say, well, read your newspaper. Newspapers these days, every newspaper almost that you pick up will have stories on our health system crisis. It's getting worse, and it's reached this crescendo where we are today. But maybe the best proof that we're in a real crisis is when our health minister, former health minister, the 44th health minister, Shane Reddy, sacked the board of Health New Zealand, appointed a commissioner, and then Shane Reddy himself was substituted by our new minister, the 45th health minister, Simeon Brown, who formerly was the Minister of Transport, Energy, Local Government and Auckland. And since he was appointed, the Health New Zealand CEO has left, the Director of Public Health has left, the Director General of Health has left, leaving these two gentlemen to carry the can. I guess replacements are being looked for. What do we as New Zealanders want? Well, I would say that we want what the 1938 Social Security Act promised us: a universal availability of healthcare as a fundamental right without barriers to access, equal access to the same standard of treatment, a preventative rather than curative focus, and an integrated, not fragmented service between primary and hospital care. I would assert that we have none of that, especially the equity question. And I take those 4 dot points, which are a summary of the Social Security Act from Robin Gould's paper. Professor Gauld will be speaking later on today. Well, what do we mean by equity? Most people have probably seen this diagram. Obviously, that first little panel is the reality. I believe that's the reality we have today. We don't all have the equal access to the same standard of treatment. We could give everybody the same height of box, and some of us who happen to be shorter than others still don't get to see the game. Or we could change the size of the box and we have what we would call equity. or we could remove the barrier completely. In this country, we used to have a program called The Fair Go, ran for 44 years. That TV program now has been taken off air, and I would say that in New Zealand, I have to ask the question, has the Fair Go gone? Well, that can be expressed in a more rigorous way, this inequality issue in terms of the Gini index. So a Gini index, which is just a number that's concocted, I won't go into any details, but an index of 1 means that everybody's equal. Well, there is no such society. And a Gini index, a Gini index of 1 means everybody is unequal, so one person has all the wealth, and a Gini index of 0, everyone is equal. So there is a spectrum of countries here. And you can see that, well, on the extreme right is South Africa, so it's really quite an unequal society. New Zealand sits sort of 2/3 of the way along this series, Australia in the middle, and here we have the Northern European countries, which are relatively equal societies. New Zealand's inequality, however, has increased over time. This is data from the Ministry of Social Development. And so over time our inequality is increasing. And this is a pretty good diagram that I like. It's a compounding index, which is plotted on the vertical axis, of health and social problems versus income inequality. But it shows a pretty good trend, a pretty good correlation here, that this index, these social problems get worse as income inequality gets worse. And over there on the extreme right, we have the good old United States of America, where there is extreme income inequality and lots of social issues. So not a good thing. But we also have inequality in our health system, because 35% of New Zealanders today have got private health insurance. That means that they get the prompt and premium treatment, and the rest of us get the waiting list. In 1992, about 50% of New Zealanders had private health insurance, but private health insurance only paid for 4.8% of health costs. I'm not saying this. This comes from an academic paper by Scott, and a similar sort of thing was put out there by Ashton and co. They came with a number of 6%. So in terms of health insurance, about 35% of the general population today, with Maori underrepresented in the health insurance stakes. So if that's not inequality, I'd like to know what is. Prior to the middle of 2022, New Zealand was set up with 20 district health boards. Those district health boards were in charge of these things here, setting strategic direction, deciding on the level and mix and quality of service, and to conduct oversight. I won't labour any of this because Ian Powell has got a good handle on the history of New Zealand's health system, and he'll be talking more about that. We used to have the old hospital where I was actually born. It was replaced in about 2014 by a new one. That new one has had a few problems lately. We've lost our obstetrics and gynecology secondary service, and that has landed this crisis right on our doorstep. So people are starting to take notice, but many of us have seen this coming for many years, including the elderly gentleman to my right there, Sandy Milne Esquire, MBE. So that's what a health board looked like. It was comprised of a mix of elected members and appointed members. That's gone by the wayside after the review that was done by the former Labor government. The health system has been reviewed many times. This was one of the latest one by Heather Simpson, who was in charge of it, and she had a panel comprising these people over here. I immediately had some communications with Peter Crampton and Dr. Lloyd McCann. Professor Peter Crampton will be speaking today. It was set up like this was the proposal of the former Labor government as at July 2022. The Minister of Health sits on top, followed by the Ministry, a public health agency, and then Health New Zealand, which most of us have probably heard most about. When the new government came in, the National Coalition, the Maori Health Authority was eliminated, and this is what our health minister said, the Labor health minister said. I think he's pretty well nailed it when he said that health real estate is very run down. There's a difference between metropolitan areas and rural and provincial areas in terms of cancer survival rates. New Zealand's cancer survival rates are significantly less than Australia's, so we're not doing too good there. Too much time and resource was being spent negotiating with DHBs because it was a devolved system. So each DHB was like an empire on its own. There's the equity question that I just alluded to, and even if even with the DHBs there wasn't much local input, and I think some of us around this table would attest to that. So those are some of the problems that former health minister had articulated. And so I want to talk about system performance here, just to see how we're going on a sort of a quantitative level. And there've been two big reviews done, one by the OECD, about 65 pages, and one by the WHO. But basically what we do is measure things. If you don't measure, you don't know where you are. What we measure are metrics. So metrics can have different dimensions. We can measure workforce metrics or health expenditure and financing metrics. But I only want to focus on a few of these today because there's just not time to do any more. There's pages of metrics. So let's look at doctors, because I think we'll all concede today that we have a shortage of workforce doctors. This is quite an old slide that I've been had in my slide pack for a while, but basically the trends are similar. Here's New Zealand over here at 3.03 doctors per thousand population. I guess what I want to point out is that the northern or the Scandinavian countries are substantially higher than us. Australia's higher than us, but here's Cuba, a country that's been embargoed, sanctioned, you name it, a wall been put around, is able to produce 8 doctors per thousand of population. We can't get anywhere near that. The trend over time from the 1960s for a selection of countries from OECD countries mostly, from 1960 to 2020, you can see that there's a linear increase in the number of doctors per thousand of population. Well, that would seem to be good, but it's more complicated than that. Why? I mean, we've got more doctors, but we don't have any doctors. So it turns out that there's a correlation between the number of doctors per thousand that we're put on and the mean life expectancy. Well, this is a graph that tells you that our health system has been so successful that it's actually it's been a victim of its own success. So as we've allowed people, or as the health system has been so effective in keeping people living longer, that's required more and more doctors. So, hospital beds per thousand. Over here on the right we have Japan, 12.5 beds per thousand of population. This data is probably, this is probably 2019 as I've written here. And New Zealand's right down on the left. We've done a good job of having very few hospital beds. But I think what is telling is this graph. Back in the 1960s, we had as many hospital beds per thousand of population as Japan did. Now, Japan, in all of the assessments of health systems, always comes out as one of the top countries. So they had 12, we had 12. But when the Longi government came in and ushered in this neoliberal era of neoliberal economics, we fell off a cliff, and then we fell off another cliff during the Clark government, down to about 2.5 hospital beds per thousand from 12. So, waiting times, that's a big bugbear in our system. Here's our waiting times over time, number of days that people are waiting for hip replacement, and you can see that we, in this selection of countries, are at top of the pops, and that you have to wait at least 200 days for hip replacement. I would argue that if we put the 2024 numbers, they're not out yet, but when they do come out, I think it's going to be substantially higher than that data point at the end there. And we're also not we're not too flash as far as coronary bypass and other surgical procedures are concerned. So we're found wanting there. This is some data that the government has talked about, the patients waiting 4+ months for their first specialist appointment. It's on an exponential curve, essentially. That's what that looks like. There it is. There she goes, shoots up. And for treatment, it's also been increasing over time. We'll see what happens as we get the latest numbers. Te Whatu Ora, or Health New Zealand, has said that we have short of 1,700 doctors in this country, 4,800 nurses, about 1,000 midwives, and so on. I think that we have a workforce crisis on our hands. So we train doctors, we make them pay more than 100,000 for their doctorate degree, and so when they finish, what do? They want to recoup the investment in themselves, and a bunch of them, I would assume, leave. Waiting times to see a GP. When I first got to Whakatane, you could easily get in within 2 days. This graph shows you the percentage of people that waited less than 2 days to get a doctor's appointment, a GP appointment. So we were doing pretty well, even surpassing Australia. Well, that's no longer the case. The last time I got a GP appointment, I had to wait about 5 months. Oh no, 5 weeks. So it's 4 to 5 weeks now. I think that's well recognised. So if you take all this together, various institutions have done analyses of the performance of health systems, and I've done I've looked at quite a lot of them, and the best we can come out in OECD countries is sort of in the bottom third. So that's in terms of performance. Financial performance, well, this graph is interesting. This shows the health expenditure per capita for all of these countries in terms of purchasing power parity versus life expectancy as a crude measure of performance of a health system, right? Your health system, if people live longer, your health system probably a bit better. But what I want to point out here is we have the good old USA right here again on the extreme right. Performance is poor, and yet it costs 2.5 times as much their health system as ours would. So, you know, I guess this is capitalism, but this is an average number, right? Which means that if you want the best healthcare in the world, you can probably get it in the United States of America, but most people don't. 35 million Americans are either underinsured or not insured at all, and so I think that that is where we don't want to be. So it's not an argument, it's the most privatised system in the world probably. So I guess the conclusion is private is not better. This is the performance of the American health system during the COVID pandemic, the number of deaths as published by the New York Times map, and you can see that the United States is not doing much better than impoverished Latin American countries. I would say we don't want to be there. Have we really been spending enough? So this is some data that's out there and appears in the paper by Lorgeley, the professor a health economist at the University of Auckland. And it would seem, these are nominal numbers, nominal expenditure, that we've been actually investing more. But there's not real dollars. And that's the percentage change over time. And you can see that in 2022 and 23, we've essentially stalled. We haven't put any more money into the system. But I would take this as gospel more than that. This is an editorial in the New Zealand Medical Journal, and one of the conclusions they make there is that official data and documents suggest that New Zealand's health system has been systematically underfunded, and our analysis of the 24-25 health budget suggests funding for this financial year is also inadequate. It is unlikely the cost overruns are solely due to financial mismanagement. So yes, we can tweak the system, but if you just don't have enough money, there's a limit to what you can do. Investment over time as a percentage of GDP, what I want to point out here is that we're tracking along the same, so we're putting more money as a percentage of GDP along with Australia. But look at the United States of America. In 1970, they used to put about 6% of GDP into health. Well, today it's over 20%. And their GDP is bigger than ours. So if this is good financial performance, I don't think it is. Somebody's doing all right, though. And of course, our health system is a market now, and markets want to grow. This is what capitalism is all about. Let's make more money. And I want to get to privatisation as the last bit of my talk. Is privatisation a problem? Well, I would say that if the most privatised system in the world is the poorest performing overall, then privatisation is not a good thing. Have we been privatising? I put this to the Ministry of Health. I said, why are we privatising? Where's your business case that proves that privatisation is economically more efficient and results in better patient outcomes? And their response to me was, we're not privatising. So the question is, are we or are we not privatising? Well, if you read some of the literature, you'll see that pathology is 75% privatised today and 40% of radiology is privatised. But that's not good enough for me. So I went and asked the Ministry of Health to supply me all the numbers. Full-time equivalents, that is a person, one staff member. What you have here in orange is the percentage of privatisation, and in blue is the percentage public. So you can see that for these 41 health specialties, a good proportion of them are well on the road to being privatised in terms of staff numbers. So if you break that down, those are 2022 numbers, and look for trends, well, this is what I was trying to do. So here we go, we'll look at 3, and you can see, well, there's no data before 2020, which was interesting. I mean, we have a Ministry of Health full of people. Why are they not even tracking these numbers before 2020? coincidentally when the COVID pandemic hit us. Okay, so here's pathology. The percentage privatisation as a function of time will essentially from mid-2020 to mid-2023, that has increased 31%. Diagnostic interventional radiology has increased 12%, and musculoskeletal medicine has gone up 18%. So those three health specialties have certainly increased over time. I don't think that's a good thing either. So let's get to the punchline here. I think that what's happened, we're in a crisis. The crisis didn't happen today or yesterday. It's been ongoing for decades. And our system really depends on how well off you are. The more wealthy you are, the more likely you are to be able to afford the private health insurance. If you get the private health insurance, you get the prompt and premium service. And if you don't have the health insurance, you get the dreaded waiting list, which is getting longer and longer and longer. So it all depends, our system, on where you are on this economic ladder. That was not the idea. That is not how the NHS, the National Health Service in England, was set up. We don't want to be a class-based system, I would say. Well, what happens is you privatise. Well, here's an example of what can happen when you privatise basic infrastructure that's critical to everybody, right? So this is the Commons. So this is the railway system in Greece, one of the worst accidents they've ever had. It happened just after they privatised the system through lack of maintenance. I think everybody agrees on that one, and I think that the health needs to be in the public system. So at the heart of this is money, and money systems have changed over time. They have a certain expiry date, but this is really not my area, and that's why I've asked Professor Steve Keane to come and talk to us about how we would finance a health system in a pure fiat monetary system that we have. How can we do better? Because all I hear from governments is there is no money, or let's look for ways of cutting. So you've got Lester Levy walking around with his financial scalpel trying to cut more meat off the skeleton. I'm speaking metaphorically here, but I'll pass it on to Steve Keane. And that's the end of my talk, essentially. Thank you very much for listening. Steve Keane is somebody I've been following for quite some time. He used to work at the University of Western Sydney, and he was one of the few economists to correctly predict the great financial crisis of 2008. He is, I guess, what you would call one of the world's premier contrarian economists, so I have great respect for Steve, because he's a guy who thinks out of the box, and he's going to give us a little bit of tour about what money is and how we can maybe help cure some of our woes in terms of financing a health system. Thank you, Steve. It's all yours.
Thank you, Victor. And I'll set myself to share my own screen here. Let's hope I get the right screen. Okay, so what you've been talking about, Victor, can you see the screen?
Yep.
My slides?
Yep.
Good, okay. What you've been talking about, Victor, is a common thread across the whole the Western nations fundamentally. This is what's driving the cutback in funding for virtually every government activity everywhere, and of course we're seeing it on steroids right now, or maybe I should say on what is it called? Ketamine? In America, the fear of the government going bankrupt. And the argument is that the government spends more than it taxes, it runs up debt, and just like a household, they will eventually be unable to get any money and they'll go bankrupt. So even though it's regrettable to cut back on health services, we have to do it to avoid bankruptcy. And that, as I said, it's very, very common argument. So it's not just New Zealand that's doing this. And the argument is that if you have government borrowing, so the government covers anything it spends in excess of taxation revenue, it covers by borrowing money. That reduces the amount of money available for the private sector. It leads to higher interest rates, and of course interest payments on government debt explode. And without any debt reduction, the government could go bankrupt. We have to avoid that. So terribly sorry, your waiting time for hip replacements is going to increase. Now that's actually taught in economic textbooks, not that particular example, but this is what's called the model of loanable funds, as taught in the Manque textbook, which is probably the dominant way that people do economics in first year university courses around the world, and most of those people are the ones who end up making policy advice about the need to cut back government spending. So savings is the supply, households save, firms invest, they borrow from the public, and if the government borrows more, then there must be a fall in investment, and therefore, these are all quotes, by the way. I've taken some text out, as you can see, from the dots, but this is quotes from the leading economics textbook. The increase in government purchases causes interest rate to rise and investment to decrease. Government purchases crowd out investment. So getting government down, you'll grow more rapidly and you can have better private health care. That's the basic idea. Now, this is how it's explained to students, and anybody who's done an economics degree would be familiar with these drawings. Anybody who's not, this is how economists tend to think. When they put their mathematical models together, it's still effectively a set of diagrams from Alfred Marshall. So the idea is there's a supply of savings and there's an investment which it rises, desired investment rises as interest rate falls. If the government gets in there, it reduces the amount available, so it cuts back the amount that can be borrowed and increases the interest rate. That's the sort of picture that people have in their heads. Now, banks themselves, strangely enough, do not manage their finances by drawings of supply and demand curves. They use double entry bookkeeping. And what I want to show is how different a picture you get when you put it in double entry bookkeeping terms, or rather how double entry bookkeeping constrains the arguments you can make. So if anybody who's done bookkeeping knows these basic ideas. In double entry bookkeeping, all financial claims are classified as either assets or liabilities. The gap between those two is your equity or net worth, and you record all transactions twice, once as a credit and once as a debit, and that's how accountants have been keeping track of spending for 700 years. Now, I do the same thing with the software package I call Ravel, which is commercially available, but to do what I'm going to show you today, it'll cost you the princely sum of $1 a month. If you want to do data analysis, $7. But what it does, it implies this same rule, and it makes sure that every transaction recorded on what I call a godly table obeys the equation that assets minus liability minus equity equals zero. And that's the fundamental check that makes sure you've got the financial system shown properly, and you have to show all transactions twice, once from the asset owner's point of view and one from the liability point of view. So when you look at the model that students are taught in textbooks, banks actually don't lend. Banks are what they call intermediaries. They enable savers to meet up with borrowers more easily than it happened on the street. So the households are effectively the lenders, and they can lend to either firms or the government. So if I put this together in my software package, this is the picture that I see as being in people's minds. You have banks who have reserves, they have liabilities, which are the accounts of households and firms and the governments respectively. And debt doesn't turn up there because the debt is actually not owned by the banks. An intermediary does not own what is being passed between other aid parties by the intermediary. So firms, if I now include firms in this model, I'm going to have firms borrowing from households and paying interest on their borrowings, governments selling bonds to cover the difference between their taxation revenue and their spending, plus interest on outstanding bonds. And what you get is a picture like this. So you have showing it the basic story. Moving my mouse, see if I can see my mouse here. Even I can't see it, so I'll have to talk out. Households borrow, that's the negative red. Sorry, no, households lend, and that means borrowed dollars per year comes out of their account, and that turns up in firms' account. Firms then pay interest. That's the flow in the opposite direction. The government sells bonds, and the government pays interest. Those are the basic financial operations there. Now, to show the whole thing properly, I hope you may be suffering what's called MIGO effect right now. My eyes glaze over. Too much in the way of equations or tables, and people tend to start going blind. But that's showing that basic picture. To show it fully, you've actually got to show 5 entities. You've got the banks, which I've already shown on the first table, but seeing the system from the household's point of view, the firms, central banks, and treasury. That's putting all that together. Now, what you see there, reserves turn up twice, household accounts turn up twice, firms so twice, the government twice. So this is the overall comprehensive picture. And then you get all the flows themselves, or the debt of firms and the debt of government. They show up on the households account. And then what I've got to now do is include non-financial transactions. So those are all transferring money between ourselves in various ways, but not getting goods and services back. Of course, you have the fundamental thing about an economy is people are buying and selling goods and services. So firms hire workers, households consume, households pay banks a fee, and this is the only way you can explain how banks make money in this system. Those poor banks just it's so hard for them to make a profit. Banks pay a fee, intermediation fee, and the banks then spend on the firms, and government's taxation and spending occur. And just for simplicity, I make a simplifying assumption. It would be no different in results if I put it more realistically. I have governments tax households and spend on firms. So I've got that little split inside the model. Now, the full model looks like this. So again, more of the MEGO effect, but all the tables you've seen there are generated by the program itself to make sure the finances are accurately covered. And when I run it with a balanced budget, this is the sort of behavior I get. Now tell me if I'm working on a very large screen, you might not be seeing my graphs very smoothly, but what you can see is this model gives you a constant GDP. There's a fixed amount of money turning over at much the same rate. I've got government debt going up, interest rate rising, but overall the system will be stable. The system, with a balanced budget, the government will not have an overwhelming level of debt. And these are now the more detailed plots. So I've got, in this particular case, I'm showing the government running a balanced budget, therefore firms are borrowing money. They're borrowing money from the household sector. Their debt is rising, but you're getting an overall balanced outcome out of the system, and there's no government debt. Now, what if you have a 1% of GDP government debt in this model? Okay, well, that means the government is spending more than it gets back in taxation. It issues bonds for that gap, and then it has to pay interest on the bonds as well, and it issues bonds for those as well, on which it has to pay interest. So what you get is the sort of catastrophe that all the governments around the world are terrified about, that you have this rising level of government debt to GDP, so the ratio goes crazy. That is a government debt to GDP ratio of 14,000%. The interest rate goes catastrophic as well. You have an interest rate of 85% per year. The system breaks down. Finally, you've got a collapsing economy. You don't want that. Okay. The thing is, you don't have to have it, because that is actually a false model. The model of loanable funds that is taught by economic textbooks around the planet was actually challenged for over a century by non-orthodox economists like myself. But in fact, in 2014, the Bank of England came out and said that the critics are right, not the mainstream, not the textbooks. Textbooks are wrong. Banks don't lend out deposits. They lend on their own account. So rather than this type of lending going on, which is a transfer between one non-bank and another non-bank, from households to firms and households to government, what you have instead is that the banks themselves create, issue debt, and that turns up as an asset of theirs and a liability of whom they're borrowing from. So this is the technical name in the academic literature for this idea used to be endogenous money. And I find that very unmeaningful. So I have come up with a different title. I call it bank-originated money and debt, otherwise known as BOMD. So, thank you for turning off your microphone, Ian. So this is what the BOMD tables look like. And what actually happens, the main difference that occurs, is that whereas before I had the debt being of the firms and debt of the government being an asset at the household sector, it's actually an asset at the banking sector. Before I had the government banking at the private banks, governments do have accounts at private banks, but they primarily bank with their own bank, the central bank. So all I've done in changing from that model of a disaster to this one is simply flip who owns the assets and who has the liabilities. No change to the equations in the model of that at all. Now, what you see is I know what looking at graphs can be like, again, the MEGO effect. What happens here, it didn't happen in the previous model. The GDP rises. The reason is government spending more than it takes back in taxation creates money, which the rest of the economy uses for transactions between the private sector. You don't get the catastrophic increase in interest rate. It levels out over time, and the debt ratio also stabilises. Government debt doesn't go through the roof. So simply changing from that vision to one where there's where the bank money, where both banks create money by lending out more than they get back in repayments, and governments create money, as I'm going to do now, by spending more than they get back in taxation. With both governments and governments creating money, fiat money, and banks creating credit money, you get a growing economy, debt ratios stabilise, interest rates don't become impossible, and the amount of money in people's bank accounts actually goes up. So rather than government spending taking money away from people, it's creating it for them. And this means that the crisis people fear doesn't happen in the real world. It is literally a fiction. It's a chimera. We shouldn't be worrying about it. What's the result of worrying about it is that we don't build the hospitals. We don't fix up potholes in the road. We don't educate people. We charge them large amounts of money where we could pay for it for things which are beneficial for everybody, like doctors. We could pay it from the public purse, which creates the money. It doesn't borrow it in the first place. So what you get out of that, and it was hard to see on that previous chart, again, it's hard to see these things in a presentation, but running a balanced budget, rather than being better by avoiding bankruptcy, actually reduces the rate of economic growth because there's less money in the system. And people therefore spend their time speculating on share prices and, dare I say, house prices, rather than building goods and services and trading with each other. So rather than avoiding a crisis, avoiding government deficits is causing a crisis. And I want to illustrate that, if I can do it very quickly, because I know, again, when I say that sort of stuff, it's on a slide, it's rather hard to see. It's better if you can see it move. So this is my program, Ravel, and I'm going to run it now with a model of loanable funds, where the government is running a 1% of GDP deficit. So I've got the government spending 31% of GDP, pardon me, and taxing 1%. And if I run this model, I'll just go over to those charts again so you can see them live there. And all the stuff I showed you in a static sense is now turning up in this picture. You've got a rising level of government debt. You can see the pink line down here is interest payments in dollars per year. And the debt's rising at 60% of GDP, 70, 80, cracking 100%, and so on. Interest payments are going through the roof. They're very slowly, but if I let it run for long enough, you'll find interest payments exceed GDP. These are all the things people are terrified about. Now, as I've said, that's because they've got a false model in their minds of how banks operate. So I can quickly say, well, let's actually fix this up. Let's go across and take a look at the table from the point of view of the private banks and say it's not true that the government banks with you. I'll just actually make that screen a bit larger. So the government doesn't bank with you. So we get rid of that. I'll go over to the household table, which we pretend that households in this model are pretended to do the lending. So the debt of the firms is an asset of the banking sector, of the household sector. No, it's not, nor is government debt. And firms don't borrow from households. The fee is silly. They don't pay interest. They don't buy bonds, and they don't get bond payments. So I've removed all that from the government system. And if I now come across to this, the central bank, I can say the central bank, as well as having reserves as a liability, pardon me, has the government account. Too much talking. I better go see a doctor for my throat. So I can now balance all this and say, well, bonds are paid for from reserves. Interest payments go through reserves as well. Spending goes through reserves. And taxation comes out of reserves. So I've now got that put together, and I just need to go back to the private banks and show, well, actually, they're the ones who own the debt of firms. They're the ones who buy the bonds. And now we just need to balance the remainder of this, the interest payments, get rid of the fee. That's silly. Everything else is correct. So I just say tell the program to balance the equity. It's a command's turning off on the wrong side of my computer screens here. So I'll just type this in. So interest by firms is paid to the banks. Interest from bonds is also paid to the banks. And I've made no other changes apart from simply saying, let's get the accounting right. Now I run this model and notice the debt ratio is rising. And this is one not with variable interest rates, by the way, this version here. And you've got rising level of interest as well. So it looks like it might be in the same situation. But notice bank accounts are rising. Money is being created, which is turning over in the firm sector. GDP income is rising. GDP is rising. People have got more money. Okay? And the debt ratio, government debt ratio, rather than blowing out to infinity, stabilizes at about 50% of GDP. So we are literally worrying about fairies at the bottom of the garden, angels dancing on the head of pins. It's that sort of logic. And if you're wondering why on earth is economics so wrong about this sort of stuff, it comes down to fundamentally the ideological nature of economics, which is built into the assumptions. It's not saying, we're definitely pro-right-wing, pro-conservative, et cetera, but if you assume banks don't create money, you get those results anyway. This is foolishness by economists. It's foolishness for politicians and journalists to follow that material. They need to know better how things actually operate, and I've just shown you how it does. There is no fiscal crisis at the state. A government like the New Zealand government that creates its own money can create the money necessary to finance the spending on health, and you will get more non-financial assets out of it. You will get more houses, more schools. You will have more trained medical staff. That's what you should be doing rather than obsessing about the government deficit.
Thank you, Steve. My eyes are glazing over. But a question from me anyway. Commercial banks especially create fresh money when they make loans. In New Zealand, our commercial banks are mostly the big banks. 95% of the banking market are Australian banks, owned by shareholders from God knows where. Some of them will be Australian, pension funds and all of that sort of stuff. How do we, given that the license to operate is given to banks by we the people, through our central bank, how do we encourage banks to not get involved in this housing Ponzi scheme that they seem to love, and actually invest in public infrastructure, which, as you said, really results in real things, real wealth?
I'd rather see the government do that, but I'd like to see the private banks financing private investment, private industry, rather than financing housing bubbles, which is all they do. And the reason that they do that is, frankly, laziness. It's much easier to lend bricks and mortar than it is to work out whether you should finance entrepreneurial ideal. I don't know, like rockets on the northern tip of the Northern Island by this crazy character who reckons he can outcompete with Elon Musk. That person couldn't exist, could they? That's what the banks should be providing money for, and they don't, because it's much easier to provide for bricks and mortar. So and when you look at the dynamics of that, the increase in mortgage credit is what causes rising house prices. You'll be pleased to know, by the way, that New Zealand tops the global list on financing speculation in house prices when you look at how the mechanics actually work. So I would simply say, put in rules in place. The banks can only operate as banks under a government license. They should be therefore operating in the social benefit as well as their own private benefit, and they should be told there are areas they cannot lend into. Now, I would, in housing, my idea has always been to say that banks can lend to no more than 10 times the actual or imputed rental income of a property. And with that, you wouldn't get the breakaway between house prices and incomes. Constrain it that way. So you also need to force banks to hang on to some of the bonds created by the government rather than selling them, because when the banks sell those bonds, that actually destroys money. So you need to have you regard banks as having a social license which they use in self-interest, and you have to constrain how extreme their self-interest can be.
Yeah, on that note, our Reserve Bank Act prior to 1989 had three objectives in it. One was inflation targeting. I think the other one was full employment. And the third one was a social objective. Well, they removed the social objective, and they've recently, in recent times, taken out their full employment objective. We're left with inflation. Should we be trying to go back the other way? How would
Yes.
we do it? Does it require a people movement? You know, you've got people from Treasury, people from the Reserve Bank, all these experts, these mainstream economists, talking to politicians who don't understand anything of very much of what you just spoke about. How is it that we change a system? And would New Zealand be a good place to do that? Because we're only a small country. We've managed to move very quickly when we turned everything over to neoliberalism. Is this really a lost cause, or is there hope?
I think there's hope, and pardon me, I've got somebody trying to call me. I've got to just decline the call for the moment. Okay. Yeah, it is a case that you have a history in New Zealand, things like social credit and so on. Innovation has been part of the New Zealand nature right from, allowing women, the first country in the world to give women the vote, and so on and so forth. I'm embarrassed to be an Australian. I'd rather be a New Zealander, given your long-term history of politics. But yes, you could. It's quite feasible to get the people to realise how the system actually functions. And the great dilemma is it's the economists, the so-called experts, are the ones who don't understand the system. They're the ones who push these myths around. And the reason why is not because they're malicious or anything like that. They've got a mental framework that Thomas Kuhn called a paradigm. And if you damage any part of that paradigm, the whole thing falls apart. So if you say that banks create money, that actually undermines all the arguments that economists make when they teach their students. And of course, they went through the same process, to believe that money doesn't matter. Ironically, the attitude of conventional economists is that money is veil over barter. Remove it, you see what's actually going on. What they're in doing, they don't understand the monetary system. Their models of the monetary system aren't there to explain how money operates. They're there to justify not including money in their macroeconomic models. It's quite ironic. So the only way to break this down is for the public to realise you've got a demented bunch of what I would call toll-make economists, people who believe the earth is flat and it's also the centre of the universe. They're running the system. So we've got to undermine it from the public point of view, which is one reason why I was so pleased to take up your invitation. We have to get this to the grassroots, and the grassroots need to communicate what's actually happening and break down this belief by a bunch of economic priesthoods who really don't understand money in the first place.
Thank you, Steve. Are there any questions from the audience? Or yes, Vince.
Yeah. Kia ora, Professor King. Thank you for the amazing presentation. I was trying to do my best to follow it. The thing that struck me with your presentation and the question that I have was like the model that you presented, was that the same approach used after the Great Depression to get economies out of the Great Depression in the 1930s?
Yeah, fundamentally, government spending got us out of the Great Depression. And the reason is that when the private sector has a private debt bubble, it's private debt that's the dangerous debt for the economy, not government debt. When you have a private debt bubble, and there was one in the 1920s, and people can no longer service the debt that they owe, they can go bankrupt. They did go bankrupt on a grand scale. That meant a collapse in credit-based money. And the collapse is so great that as well as GDP falling in real terms by about 10% per annum in the early days of the Great Depression, so did the price level, which meant nominal GDP fell by 20% per annum. So that amplified the downturn. And in that situation, there was no way credit money was going to get us out of that trap because, as Irving Fisher put it, when you've got falling prices and people paying down their debt, but their debt ratio rising, as he put it, the more debtors pay, the more they owe. Now, the only way out of that is government money creation, injecting money in which doesn't come with debt in a realistic sense for anybody, because when you get government money doesn't cause debt for you, and government money causes the government to sell bonds to avoid its central bank account going into overdraft. But that's really the only practical impact of bond sales. The government could do the whole damn thing without bond sales, or they could sell the bonds directly to the central bank and bypass putting them into the private system in the first place. So it is just, it's such a naive idea of how the economy operates. Once you show people how it operates in a banking sector, particularly show it to engineers, we'll get this stuff much faster than other people. We might be able to overthrow that conventional wisdom, which is so completely wrong about how a monetary system actually operates.
Thank you, Steve. Are there any other questions from the audience? No? Well, I think in the interests of keeping to schedule, thank you very much, Steve. You're one of my heroes. Keep doing what you're doing. I hope we can change the world. But anyway, one step at a time. Thank you.
Indeed. Thank you, Victor. Okay,
Thank you, Steve.
I'll head off and go and have dinner. Bye, all.
Cheers. Our next speaker on our list is Professor Robin Gauld. Not online yet, but I see that we have Professor Peter Crampton here. Are you ready to go, Peter?
Kia ora. Yes, I'm ready to go. Victor, am I showing my slides or are you sharing them from your end?
You can share them.
Fine. Okay, let me just give me a moment. I'll get them up.
Well, Professor Peter Crampton is a Professor of Public Health in Kohatu, the Centre for Haura Māori, University of Otago. So welcome, Peter. Thanks very much for doing this. As I mentioned before, you were on the Simpson review panel, so your insights into this area is about as deep as anybody's. So we look forward to hearing from you. Thanks, Peter.
Thanks, Victor. Am I sharing the screen?
Yep.
Can you see the slides?
Yes.
Sorry, was that a yes?
Yes.
Yeah, great. Okay. Okay. Well, look, thank you, Victor. And it's a pleasure to be here with you all. Those were two wonderful presentations just now. So, look, I'm changing gear a little bit. I'll be talking about primary healthcare, the foundation of our health system, and in particular what we need to do to shore up that foundation and to protect it. So my name is Peter Crampton. I'm a Professor of Public Health at the University of Otago. And that's a picture of my house at the bottom right. In winter, and I dare say that you don't experience that sort of winter where you are. I started my professional life as a general practitioner, helping to set up a Union Health Centre in Porirua on the eastern side of the motorway there in Cannons Creek. And that was a time of huge learning for me, and it really did set the path of my career. So I worked as a GP for a number of years there before moving out of that role and then studying public health. And I've spent the balance of my life working in academic public health in a university context, but working a great deal with government agencies and with policymakers over the years. And there are pictures of my family here in Dunedin. All right, just some acknowledgements. So I would like to thank you again, Victor, and all those who've contributed to organising this conference. I want to say thank you to a particular group, the Primary and Community Healthcare External Advisory Group, sorry about that long title, which was established by the then Director General of Health, Dr. Diana Safeti, last year, to give advice to the Ministry of Health on primary healthcare strategy. And I'm drawing on the thinking of that group in some of the comments I make in this presentation. My interests there listed just for the record, the various committees and groups that I'm involved with. All right. So I'm going to make some preliminary observations about healthcare systems. And then I'm going to talk about primary healthcare specifically, and primary healthcare in Aotearoa, New Zealand, and then the current state of play, and then what I think we need to be doing to, as I said before, strengthen, shore up, and ensure the sustainability of that foundation of our healthcare system, primary healthcare. First, some preliminary observations. Perhaps statements of the obvious, but nevertheless profoundly important observations in terms of shaping and conditioning our thinking about how we approach health policy. Firstly, a healthcare system is an expression of our collective values, and it is always, a healthcare system is always values-based. And the sorts of differences in healthcare systems that Victor referred to before across different countries reflects underneath that differences in shared values of those societies to some greater or lesser extent. And the Social Security Act of 1938, which established the welfare state in New Zealand and also set up our modern healthcare system, perhaps the third in the world at that point, following Germany in the 1890s, I beg your pardon, second in the world at that point, following Germany in the 1890s, and then ourselves in the late 1930s, and then the National Health Service is 1948. Those national health systems all reflect the values of those countries. Health systems are sometimes referred to as complex adaptive systems. Sorry about the jargon, but it's important. There is a distinction to be drawn between complicated and complex. Complicated systems have many moving parts, but are ultimately predictable and understandable. Like the inside of your mechanical watch, if you have one, is complicated, but it's understandable and predictable. A complex system is complicated, but with the added feature that it's unpredictable. So if you poke one part of a complex adaptive system, there will be responses in other parts of the system which you would find very hard to anticipate. Now, what that means is that when we're implementing healthcare policy, all we can hope to do is to test, monitor, and adjust, because we're not entirely sure how the system is going to respond to a new policy. There will be some anticipated responses and perhaps some unanticipated responses to any new healthcare policy, because the healthcare system is a complex adaptive system. So health policy is always difficult. It's difficult to formulate and it's very hard to implement. And there are more examples of poorly implemented health policies than one would care to talk about in our recent and also in our distant history in New Zealand. The international context shapes our discussions about healthcare policy to some greater or lesser extent, particularly around health workforce, but also in terms of the influence of trends and fashions in terms of thinking. Our local context right now, as Victor has clearly described, is complex and uncertain and very fluid. I've been working in the area of healthcare policy for, let's say, 30 plus years. I've never experienced a time where I believe that I personally, and probably most people, feel more uncertain about the direction of the healthcare system, what our health policies are, what the direction of travel is. This comes on the back of a set of changes that the previous Labour government introduced, a set of restructurings using the PI or a Healthy Futures Act as its vehicle to introduce those changes. They were poorly implemented and only very partially implemented at the time that there was a change in government, and then our current coalition government took up that complex and difficult and challenging set of circumstances and has made its own sets of changes And as part of that, there's been extraordinary leadership churn at the very highest levels in the healthcare system, which in itself, aside from any other factors, is quite destabilizing and amplifies a sense of uncertainty and lack of clarity. Specifically in relation to primary healthcare, we have diverse ownership forms. One might call it a mixed economy in primary healthcare. Private for-profit ownership is the dominant model. In addition to that, we have government ownership. And also we have a very important ownership form, the non-profit form in primary healthcare. And I would say there's a fourth, which is more emergent in nature, and that is iwi ownership. Iwi and also Māori ownership of healthcare services. And they share characteristics with some of the above, with some of the other ownership forms, but I would say that they are sufficiently different in some respects as to be classified as a separate ownership form. So there are some background observations. I'm now going to turn to primary healthcare and just try and unpack this language a little bit. And if anybody recognises that city, I don't think you will, you can unmute yourself and tell us what it is, otherwise I'll tell you. And the question is, why is it important to our discussion today? Those are, I think, in the west referred to the Pamea Mountains, and that city is currently known as Almaty, and it is the capital, it used to be the capital of Kazakhstan, and it is the largest city in Kazakhstan. Its former name was Alma-Ata. And the World Health Assembly was held there in 1978 in what was then the Soviet Union. It was a republic of one of the republics of the Soviet Union, Kazakhstan. And they hosted the World Health Assembly in Alma-Ata in 1978. And the Alma-Ata Declaration of 1978 sets primary healthcare, sets our understanding of primary healthcare as being the foundation of a national healthcare system. And it was a hugely influential declaration, and it defined primary healthcare as being that component of the healthcare system which is available to all people, close to communities, and providing the majority of healthcare services to us all, and also having a profound pro-equity effect, pro-fairness effect in our healthcare system. There was perhaps the World Health Organization's and the UN's perhaps most lofty ambition of all ever was health for all by the year 2000. And the World Health Organization declared that that would be achieved through the provision of primary health care to all people in all countries. And the Alma-Ata Declaration hugely influenced the thinking which went into the 2001 primary healthcare strategy in New Zealand, and that was led by the then Minister of Health, Annette King. And that strategy is still current in many ways, and is desperately in need of an update and a modernisation. It was a very strong strategy, it was very influential, and much of it is still highly relevant. However, 25 years later, things have moved on, and we need a new strategy. So just to reiterate, the Alma-Ata Declaration defined primary healthcare, that component of services provided in communities, think dentists, doctors, optometrists, physiotherapists, pharmacists, etc., as being universally accessible, as requiring community participation in their governance, and as being fundamental to social and economic development within a country, and being important as a pro-fairness device in our health system. So the component of the US healthcare system, just thinking back to some of Victor's comments, that is weakest overall is the primary healthcare component. So, Victor, you made some claims for the US system, which are only partially correct in my view. You said some of the most excellent care is available in the US. I would rephrase that and say some of the most technologically advanced and specialized care is, without doubt, offered in the US. So if you've got a rare cancer, which requires highly specialized care, the US is a good place to be if you've got the requisites, health insurance. If you've got diabetes, which is a long-term condition requiring team-based care at the primary healthcare level, you're much better off in New Zealand. So it does depend a bit what sort of care you're seeking in terms of how you judge our healthcare systems. Right, in New Zealand, coming back to the Social Security Act that Victor referred to, it set up a public healthcare system, and its intention was for all components of the healthcare system to be public, including hospitals, including general practitioner care, including maternity, medicines, laboratory tests, etc. And that aspiration was not entirely achieved because the government of the day, that was the first Labour government, ended up in a huge scrap with what was then called the New Zealand branch of the British Medical Association. And the New Zealand branch of the British Medical Association wished to retain general practice in the private for-profit sector in receipt of government subsidies. So it very strongly resisted socialisation of general practice. And that is why, right up to today, the majority of general practices are located in the private for-profit sector, not formally within the public healthcare system, in receipt of government subsidies, but not mainly fully funded, and not in the control of government in the way that, for example, public hospitals are. The shadow of that political fight has been a very long one. In the 1990s, the first sets of huge changes occurred, and that was where the quasi-market was introduced into the New Zealand healthcare system by the then Minister of Health, Simon Upton. And for the first time ever, GPs were subject to contracting. All GPs had to enter contract with the government. So it was the first real formal accountability mechanism for GPs imposed by government. And that led to also a huge number of other developments. Along with that came the development, the explosion of Māori and Pacific providers throughout the country at that time. It was a time of innovation and change from that point of view. And the independent practitioner associations formed, etc., etc. So a time of huge change. The primary healthcare strategy from the then Labour government, Annette King was the Minister of Health, 2001. And then I'm going to leap forward to the Pai Ora legislation, which was passed in 2022 by Andrew Little, Minister of Health, setting up Te Aka Whai Ora, the Māori Health Authority, the iwi Māori Partnership Boards, localities, and so on. And of course, Minister Little decided to centralise the entire health system, the entire public health system of 20 district health boards, as they were then, into one entity called Te Whatu Ora, Health New Zealand. That was without doubt the largest merger in New Zealand's history, and represents a huge centralisation of power and control within the public healthcare system, within the public hospital system, within one organisation. I sat on the Health and Disability System Review Panel, chaired by Heather Simpson. As Victor mentioned, we provided advice to the government back then. That panel was established by David Clark, the then Minister of Health. And we provided advice on a wide range of things. That advice is available online in 2 large reports. We recommended reducing the number of DHBs to 8 to 12 in number, and having a central agency called Health New Zealand, comprised of the chief executives of those 8 to 12 district health boards, so that there was a more unifying influence from the centre over the top of 8 to 12 district health boards in the event that advice was not taken and the entire system was centralised. Since the introduction of the Pai Ora Act in 2022, this government has scrapped Te Aka Whai Ora, the Māori Health Authority. It has more or less scrapped the localities, which were highly relevant to our discussion today, but I won't talk about them because they're effectively gone. And it's left us in a state of considerable uncertainty about the future of many components of the healthcare system. So that's just a cartoon from back in the day. That's the then Minister of Health, Peter Fraser, trying to pull the British Medical Association horse into the water of the Social Security Act to drink. And that's Michael Joseph Savage, of course.
You need to share your screen, Peter.
Oh, you're not seeing this?
No.
Ah, I thought I asked that you were, and you said you were.
We were.
Ah, okay. Let me unshare and reshare. When did that stop?
About 2 slides back.
Ah, okay. So,
But you're doing such a great job of articulating that it's very clear what...
Okay. Let me try sharing again, and you can tell me whether I am successful. Hold on. Let me just do this. Right.
Yeah, that's it.
Okay. Now I'm just going to put that onto screen view. Tell me if you can still see it. Can you see that?
Yep.
All right. So that's Peter Fraser pulling the horse and Michael Joseph Savage trying to shove the horse into the waters of the Social Security scheme. Right. So the current state of play. In keeping with our national habit of poorly implementing policies, the 2001 primary healthcare strategy was poorly implemented in some important respects. And I would say more or less since then, it's been an area of policy neglect. There have been lots of changes, but they've been piecemeal and a little bit ad hoc. And as of now, we still have no new primary healthcare strategy. It's intensely frustrating and very, very difficult set of circumstances for everyone working in primary healthcare because there is simply no clear sense of direction of travel, what the future might look like, what our aspirations are as a country in terms of primary healthcare. And Minister Reti, who was the former Minister of Health before Minister Simeon Brown took up the role very recently, was very keen on iwi Māori partnership boards as a vehicle for achieving innovation and change in primary healthcare. We have not yet heard from Minister Brown as to what his aspirations for those iwi Māori partnership boards are. I won't talk much more about iwi Māori partnership boards, but if anybody has questions about them, I'd be very happy to answer those questions. Of special importance, we have a very out-of-date funding model for general practice and associated services. And consequently, there are huge sustainability, access and equity problems throughout general practice and primary healthcare in New Zealand now. That's a big problem. And we have a lack of clarity around what is desired in terms of ownership of primary healthcare. Let me just comment that around 25% of dentists now work for a corporate, Lumino or one of the others, and that percentage is going up, I believe, all the time. The same sort of trend is now happening in general practice, where corporates are moving in and owning entities which provide primary healthcare services. I can't quote percentages, I don't have any, but just to say it is a trend, And we also have some new sorts of service providers entering that space. One example of that is Tend, T-E-N-D, Tend. They were the founders of My Food Bag, I think, and they've now entered primary healthcare with a virtual healthcare provision model with some associated face-to-face services. My assumption is, and this is yet to be verified because we haven't heard from them in this yet, but my assumption is that there is a default probably tendency for this government and this Minister of Health to favour private for-profit provision. Perhaps they favour corporate provision of primary healthcare services. We don't know yet because there haven't been any announcements on that. But just to say there is a lack of clarity in terms of our direction of travel on those points. And as another aside, for adults, dental or oral health care is entirely in the private for-profit sector with effectively no government subsidies. Actually, there are. You can obtain government subsidies for and or service provision in public hospital dental clinics for emergencies only, for dental emergencies only. But for many, many adult New Zealanders, dental health, ordinary, preventive and restorative dental health care is beyond the means of so many families. And that is a national shame. And it is, of course, a fundamental component of primary health care, which also suffers from extreme policy neglect over the entirety of the duration of the history of the modern New Zealand healthcare system. So moving on to what we need. So these are some reflections. It's a only partial list of some of the things that we need for primary healthcare, not the totality by any means, but just some indication of what I believe is important and very urgently required in terms of policy development for primary healthcare. First of all, leadership, and perhaps this may be seen as a statement of the obvious, but we need leaders who are able to state values very clearly, to articulate those values. Without value statements, we're left adrift, because healthcare provision is fundamentally a values-based undertaking. As I said before, it's an expression of our collective values. Without those values being articulated, we are cast adrift. Because the US values of equity, freedom of choice, of self-reliance, self-responsibility are fundamentally different to our traditional values of fairness of provision for all, quality of service provision for all, etc. Fundamentally different sets of values there. They must be articulated. Our leadership of the system must have a system-wide view. It must be able to take into account the complexity of the system, the interaction of the myriad moving parts, and have a clear understanding of the nature of the system and its unpredictability. Leadership must build on the known strengths of our system. We have many, many strengths in our system. In many respects, it's an excellent system and serves the needs of many people really well. Those known strengths must be built on. And there must be an investment in leadership in all parts of the system, but here I'm referring specifically to primary healthcare and community settings. New Zealand society and knowledge of our constitutional arrangements has developed rapidly. We've had a constitutional debate foisted on us in the last 12 months. I frequently ask audiences of all types the question, do we have a constitution in New Zealand? And generally I'm met with blank looks. People simply don't know. Well, the answer is yes, we have an unwritten constitution, a non-codified constitution, if you like. And as part of that, Te Tiriti o Waitangi was an agreement between two sovereign nations, two sovereign peoples, and forms part of that foundation, constitutional foundation. As everyone is aware, over decades now, since the 1970s, there has been a revitalization, a re-emergence of Māori culture, language, participation in mainstream society. So I would say that Māori leadership in the healthcare system is absolutely vital, and the participation in decision making and service provision, commissioning, etc., is vital. And because sadly, Māori have so much skin in the game when it comes to provision of equitable health services, and by that I mean that health status of Māori is poor, so iwi leaders and Māori service providers are acutely aware of that and deeply committed to addressing that. That's what I mean by skin in the game. Their people are affected. And because Māori service providers provide services to everybody in their communities, there is a vehicle for innovation and pro-equity service provision, which was fully recognised in the formation of Te Aka Whaiora, the Māori Health Authority, which has since been disestablished. I would say that at the heart of our thinking, we need to place the healthcare needs of people, whānau communities who have the highest needs, those most in need. Design systems, policies, processes, services around those people and communities. Put them at the centre, not at the margins. And that means specific policies, bespoke policies, minimum service expectations, appropriate ownership models. Usually they will be either government owned or non-profit or iwi owned. And specific and bespoke funding mechanisms recognise the cost, the real costs involved with providing comprehensive primary healthcare services to those most in need. Victor, can I just check, are you still seeing the slides?
It's all good, Peter.
Good. At the moment, probably none of the people in this room can actually say what are legitimate expectations are of service provision at the community level in terms of what are we entitled to? What can we get free? What is subsidised? What is not subsidised? We'd know some of that in our heads and through our own experience, but not all of it. So I think there needs to be work done around what are the minimum service expectations for all people in Aotearoa, wherever they live, whatever city, provincial, centre, rural community they live in. Those are the things that you should get as of right, as a citizen. Sorry about the jargon. Meso-level organisations in primary healthcare refer to the primary health organisations or IPAs or other structures which essentially work with collections of general practices, generally geographically based. We need clarity about the roles of those organisations. Currently they're called PHOs, primary health organisations. I anticipate we'll be seeing change in this space with the current government, but I don't know that because no announcements have been made. But they fulfil a crucial role in our primary healthcare system. We need clarity on that, how they are to be structured, the roles that they will fulfil, and how they interact with Te Whatu Ora Health New Zealand. Models of service delivery. There's a lot of hype at the moment about telehealth or virtual healthcare, whereby you seek and receive healthcare via video conference with a health professional, or indeed by phone, in fact. I would say that is only ever going to be an adjunct to high quality care, not at the heart of the model. The large experiment with that, called Babylon in the UK, Babylon was a large commercial provider which moved into primary healthcare provision with a lot of fanfare. and quickly worked out that you can't do that virtually entirely. They needed to own general practices. Their business model collapsed, actually, because they hadn't actually factored in properly the ownership of general practices so that face-to-face provision could be provided. It'll be interesting to see how TEND, that company I referred to before, fares in New Zealand. So the models of care matter a great deal. With an ageing population, which we have increased complexity of healthcare provision, increased prevalence of long-term conditions, and often multiple long-term conditions in the same person, face-to-face team-based care in our communities, so that you can access the GP, the practice nurse, the nurse practitioner, the physiotherapist, the pharmacist, etc. Team-based care is absolutely the heart of quality there. So models of care need a great deal of work and definition. The funding system is way out of date, inadequate, and completely unsatisfactory now. It's old. It was introduced in the early 2000s. It needs to be updated. Aside from that, but not unrelated, we need clarity and principles applied to what we pay for and what we don't pay for out of pocket. Some patients pay co-payments at the GP, some don't. Pharmacy co-payments, optometry, hearing aids, glasses, spectacles, etc. It's a complete mishmash with no particular logical coherence about who pays for what, when, why, or how. So we need clarity around that. Workforce is possibly the most pressing health policy issue, and if not the most, it's one of the most. We need a health workforce that is as much as possibly locally grown and trained. We need the right numbers, we need the right skill mix. We need full and proper participation of Māori and Pacific people in the health workforce and all the other communities served by the health system, by the health workforce. They all need to be represented in the health workforce. We need a system which is not frozen or log jammed, so that we can foster flexibility and role innovation and career progression. And last of all, I think we need the system enablers, the infrastructure that allows our system to function properly and to provide high quality healthcare. The digital infrastructure is massively important. We need data standards and systems interoperability. We need data universally available within the health system for planning, monitoring and reporting, authoritative data that we can all trust. And amongst other things, we need infrastructure in primary healthcare for teaching, training and research. Generally, that infrastructure has been invested in over many generations in hospitals, where teaching, training and research are the norm. That same infrastructure has not been invested in primary healthcare in the community-based settings in anywhere near the same sort of way. And our system is considerably weaker as a result of that lack of investment. We need to do a catch-up on that so that we have health professional trainees and students learning in equal measure in community-based settings as in hospital-based settings. So, in summary, primary healthcare is the foundation of a healthcare system. Healthcare systems are totally reliant on high-quality healthcare, primary healthcare, and where that does not exist, we all suffer as a result of that, and costs go up. Strong primary healthcare drives population health improvement and also fairness of health outcomes, equity of health outcomes. Right now, we have long-term policy neglect of primary healthcare and also long-term underfunding of primary healthcare. These are very pressing and urgent healthcare policy issues which must be addressed in my view. As a result, we have problems with access, waiting times, fairness, and also sustainability of the system. And we must invest in strategy, leadership, etc., so that we can regain some sense of direction and clarity about where we're going, where the priority areas for investment are. And with that, Victor, I will say thank you very much. I hope that was a helpful perspective from the point of view of primary healthcare. I'm going to stop sharing that, and very happy to field questions, and I'll be around for some time longer this morning too, so if they come up later in the morning, very happy to field questions later on as well.
Yeah, thank you, Peter. Wonderful talk. I've got a question. We're heading into a hole. It takes 10 to 12 years to train a doctor, and even then they'd only be junior doctors. We've engineered our system almost, I think, deliberately to not focus on local training, which is what you was doing, but to go to an international jobs market. We're now going to pay the price because even the international job market is not exactly flush with doctors. In fact, there are many other countries that have doctor shortages. I guess COVID and some of the grim situations in which they have got these doctors have to work has caused them to exit the workforce earlier than they might otherwise have done. How do we get out of this?
Yeah, well, as I said, this is possibly health policy issue number one. So just for your information, around 42% of New Zealand doctors are overseas trained, so that we've imported them. We also export quite a few doctors, so it's an international market for doctors. So recruiting locally, training locally, holding locally is hugely important, and that's a really hairy and difficult set of issues, and we have not cracked that. Neither have other countries, by the way. Maybe with the shambles going on in other parts of the world, we'll find it increasingly easier to retain our own locally trained doctors. We may find it easier to import doctors from overseas, from the Northern Hemisphere. But that, of course, is that's all happenstance if it does become easier. There's a lot of talk at the moment about the coalition agreement to start a third medical school in the University of Waikato. There are currently 2 medical schools at the University of Auckland and Otago. They're both very big medical schools. Your statement that it takes 12 years, whatever you said, to train a doctor, yeah, well, 15 once, before you got a specialist, a fully trained specialist, 15 or more years. So it's a very long lead-in time. And you were dead right in making that observation. So as a society, we need to work out how we're going to make that long-term investment. And at the moment, the government's grappling with the issue about whether or not to invest in a third medical school at the University of Waikato, or to just tip extra students into Auckland and Otago medical schools. And one can debate the pros and cons of those two approaches endlessly. But just to say that these are incredibly pressing issues for medicine. Similar set of comments can be made of nursing as well. Although there are many more nursing providers, education providers in New Zealand, many of them located provincially, and that's a huge strength of, I believe, of nursing education. So, yeah, Victor, if we had the answers to those questions, we'd be the better for it, but it's complex.
Yeah, well, we've got into this situation because the decision-making of the last several decades hasn't been really good enough, very short-sighted. Even if we pressed the green button today and money wasn't an object, it would still take a long time to get that workforce issue sorted. But thank you, Peter. Are there any questions from around the table or among the audience for Peter? I've got another question then. You talked about leadership. We're a small country. I get the impression, without doing any numbers, that we're kind of top heavy in the administration and management areas. Got a paper in front of me dealing with the UK system, says that there was an increase of 35% in NHS staff, but the number of managers increased by 82% in a 10-year period. Are we at risk of, I mean, it would be nice to know the ratio of managers to actual clinicians and hands-on staff over time. I'm not sure if those numbers are readily available, but are we at risk of just piling in managers and not the people? I don't want to talk to a manager when I end up in hospital. I want to talk to a doctor. I need a doctor. So what would you say to that?
What I would say to that, Victor, it's a great question, is that these two initial points. Firstly, there's a lot of political rhetoric around this, and we need to be aware of that and sensitive to that. I mean, government uses the code words of frontline services, coalface services, etc., and perhaps diminishes the importance of proper backroom services and non-frontline services. So that's all the political rhetoric. Let's put that aside. My view is that when we had 20 district health boards, we had too much leadership, governance, management of our healthcare system. That was my personal view. For a small country, there was simply, it was out of balance. That's why we, as the Health and Disability System Review Panel, recommended reducing the number of district health boards, not removing them altogether, but just reducing the number. Do we have the balance right now? Well, it's a fascinating and extremely timely question. I don't have data to hand. Ian Powell might. I don't know any accurate measurement of backroom versus clinical service numbers. The commissioner, Professor Lester Levy, is currently swinging the restructuring ball through to Whātua Ora Health New Zealand, and many people are being removed from their roles. Again, I don't have numbers, and I'm not aware that there are any public numbers on this. Again, Ian might have some numbers. Is he getting the balance right? I don't know. Some of the things I hear are truly alarming when we, just locally here in Otago Southland, the proportion of the IT staff being disestablished. If those numbers are correct, I find I just can't see how that can possibly work. And so I don't know the answer to your question. It's a huge system, and it's a complex system, and it's entirely reliant on the quality of its basic core infrastructure. So it's easy to say we've got too many managers, but by manager, do you mean the person who runs the IT system in your local hospital, or the team of people who do that? Well, possibly you do mean that, in which case, be careful what you wish for. Big set of imponderables there from my point of view. We need more data, and I think without data, then it becomes very hard to have a well-informed discussion.
Yeah, no, absolutely. I mean, that's sort of what I was alluding to. You can't fix if you haven't even if you're not even measuring, and that's what I found out with the public-private split. If they don't even go back before 2020, we're not in good shape. Thank you very much, Peter. We have a question.
Yes, thank you.
Microphone.
Victor, I've got a comment. Seeing
Sure.
Peter enticed me in. I'm not aware of a measurement as such, but I'm not sure that's the right way of approaching it. And the term back office has been used in the past and now in a demonising way. Many of those roles that are come under the broad umbrella of management are actually quite integral to what people do in the clinical frontline. I remember a paediatrician saying to me some time ago he'd much rather be an underpaid paediatrician than an overpaid secretary. They are integral. In some of the estimates that have been done before, not estimates, but assertions, and what comes under the management umbrella, they include charge nurses. Now, that's clearly a clinical role with a particular leadership responsibility. So I think we have to be careful that we're not demonising a workforce that is largely unseen, but is quite critical to actually enabling health professionals to do what health professionals do best.
Thank you, Ian.
And just, Victor, I totally agree with those comments from Ian.
Thank you. There's a question down at the end of the table.
Oh, hi, thank you. Recently we found out that Whakatane Hospital has just been allocated, I guess, a manager after years and years and years of not having a manager, and basically our local hospital being run from Tauranga. So I can see there is a point in having a manager for Whakatane, for, you know, staff being, knowing what the requirements are for our hospital. You know, we are so lacking in any management because they've been resigning and nobody's been there sort of picking up the reins and saying, right, we need to get other people. It's basically been remotely managed. So I can see there are definite places for management, especially in our area, which gets ignored.
Yeah, look, I agree with that comment, and it's possible to think about optimal levels of management, but from my point of view, in health, management, like all other patient-facing activities, is relationship-based. So managers must be local, in my view. They must have their feet on the ground, and their lived reality must be the day-to-day experience of that particular health service. So yeah, there's no doubt in my mind you need the right level of management, whatever that might be.
Thank you, Peter. There's a question over there. Yep.
Morning.
Closer.
Morning. I'm Rachel. I'm a health planner and have been in health for over 20 years. Kia ora, Peter. Thank you very much for your speech and your whakaaro on this. A part of our local problem is the lack of recruitment short-term for obstetricians in Whakatane. So this is an example of what's happening long-term, as Victor alluded to. We have a lag time of 15 years by the time we pump out some specialists. But in the short term, acknowledging that the medical school and a long-term strategic plan is great, but there's a chain of thought that's been presented to us around overseas specialists not being able to come here for 12 to 18 months due to various visa, medical research council barriers, ... With the current, and you said before, the current world events, New Zealand might be looking more attractive to a lot of people. It's probably a question for Peter and Ian as well. What's your whakaaro around the statement of this 12 to 18 month period of getting people in and on the ground? Is that legitimate, or can you see ways around that, collaborating with other, example DIA and other Crown entities, to actually get people in and working sooner?
I don't have a good answer to that, but certainly I'd rather the medical council was cautious than incautious. But I think one of the challenges that the medical council of today and in recent years has had is what's sort of sometimes called generalism in medicine and subspecialisation in medicine. It used to be that you could recruit someone from the NHS, for example, and have full confidence that the broad training they did was suitable to what we require in a relatively speaking more generalist country like New Zealand. However, there's quite an international trend towards a greater degree of subspecialisation. You would not recruit, for example, an orthopaedic surgeon from Germany who worked in a university hospital, because overwhelmingly the work that they do is in outpatient clinics, not on the operating theatre. I think the experience in England now, in the UK, is that you've got to have a lot more scrutiny about whether they can do the full range of things, such as in general surgery, that what a general surgeon would do in New Zealand. So it's not an answer to the question, but it is actually quite complex, and it's actually driven by processes that we have no control over. Just as we have to be careful about, do scrutiny checks on people who are being recruited from health systems that are more generalist than ours, we also have to be careful in those that are actually more subspecialised than ours.
Yeah. Kia ora, great question. I've got very little to add other than to say that the process of someone resigning a job, going through the process of scrutiny, emigrating, family requirement, I mean, it's complex for people to do that, often, not always. And the medical council approval process is only one step in that. It may be realistic to say that, you're looking at 18 months from the get-go to get someone actually enroll in whakatane.
Thank you, Peter. There's a question from Sandy Milne, and then I think we'll move on to the next speaker.
Hello. I'm responding to this fear about getting rid of too many people, doing a sort of Trump-like action, getting rid of people who you later regret losing. But I have comments myself. I've been leading two or three campaigns, and I have to say that in my dealings with the MOH, Ministry of Health, and the district health boards are now defunct, there's a lot of mischief going on. These places, they're so obstructionist, and I've got feedback from various government MPs and opposition MPs that are having difficulty getting in bad advice. Some of them are dreadful and mischievous, and I've got a heap of files to prove it. They really can prove it. That's one thing. The other thing is that I still, although I'm focused on lab issues, clinical laboratory issues, I'm still interested in the whole health system. And I think what's needed is audits of what's happening. For example, I watched closely as COVID vaccinations were given 2 or 3 years ago, the bulk vaccinations, and I thought, my gosh, it couldn't be more inefficient. And I should know, because I gave thousands of vaccines, and I was working, I could have produced or given 10, changed the system and given 10 times as many shots in a day. And the other thing I noticed recently, or last year or so, there seems to be a distrust among specialists for the nurse practitioners. And I had a perfect example when I went with a friend to Taronga, and I saw a cancer specialist, treating a patient, and he gave the same talk, a 40-minute talk, as the nurse practitioner gave the same patient just beforehand. I thought, how inefficient is this? So there is room for the audit, there is room for examining how every department or every area is run. That's all.
Thank you, Sandy. Do you want to respond to that? I think it's more comments than questions.
I just did not know. It was really a response to the fact that we mustn't get... we've got to review the performance of the people in the work at the moment. We mustn't be nervous about getting rid of the bad ones.
Okay. Thank you, Sandy. Thank you, Peter. Thanks very much for agreeing to do this. Wonderful. We've now, since you've replaced Robin is back. Ian, so between Robin and Ian, who wants to go next? I'm not sure whether you've got schedules or not.
I do have a schedule in the sense that I have border collies. I'm the only adult in the house, and one is about to be picked up for a pack walk very soon. So I wholeheartedly nominate Robin to go now.
Okay, all right, Robin, you're on. Thanks. And nice to see you. We've communicated by email, but I don't think, I haven't seen you in person, but anyway, in the other end of the screen. So Robin Gauld is Executive Dean of Bond Business School, former co-director, Centre for Health Systems and Technology, University of Otago. Thank you, Robin.
Morena, you can hear me okay?
Yep, and we can see your presentation too.
Great. Look, wonderful to be here today. Thanks for the invite, and thanks so much for all the work you've put into bringing this meeting together. I think it's a really important initiative. I'm on a slight time frame. It's 7:27 a.m. here, and I need to be gone by about 7:45. So I will just whip through things. And I'll just say to those in New Zealand, especially those in the far south, it's another gorgeous morning here. I've been out walking. It was 22 degrees. Sun was up at 5 a.m. It's a beautiful part of the world. So on to the very important topic, and I think this sort of follows on quite nicely from some of the points that Peter was making. Why we need to be thinking hard about national health insurance if we're serious about equity, and also in a context of, and that's the point that Peter was making that I wanted to pick up on, if we've got a government that, and again, we don't know, but if we've got a government that has interests in more private provision, then this makes it all the more important that we think about the funding dimension of the health system, and national health insurance is agnostic of public or private, but it has the goal of equity. So I just want to cover these 3 points. So funding models and health systems, why we might think and how we might think differently about funding in New Zealand, and where national health insurance would fit in. So we have basically 4 types of funding in health systems globally, with variations of this in different mixes within different jurisdictions, of course. And in New Zealand, we have the top 2 in place, as well as a bit of social insurance, we might say, through ACC. The medical savings accounts are an unusual arrangement. You'll find these in Singapore, and some other countries have experimented with medical savings accounts, but they've not been very successful with this. And that's because they're not Singapore. In Singapore, of course, if we go on to different types of health systems, actually, I think I've got the wrong slide set. I did some updates, and I had sort of Singapore actually in a bubble across here. If you can see my mouse moving, there was Singapore sort of sits across here because you've got a lot of government control in Singapore, a huge amount of government control, and that sits behind the scenes of the prices that are levied people through their medical savings accounts to pay for care, as well as through the co-payments that people levy. And so there's a lot of control, and most countries that have experimented with medical savings accounts don't have that level of government control and intervention. When you think about a market, an economist, they often think about, how does a market work? So, and what do we need to intervene in? So Singapore's a very interventionist government, and that's the only reason why the medical savings accounts sort of work in Singapore, although they're highly inequitable. So these are your different kinds of health systems, and of course there are implications for things like spending life savings. Thinking about the United States and picking up on the point there, I mean, the US is the country with the highest number of bankruptcies in the world due to inability to pay healthcare bills. And the typical story is a person who's homeless, may once have been gainfully employed. They had a healthcare condition. Their insurance became problematic once they lost their job because of the healthcare condition. Then they lost their insurance. Then they lost their house. Then they lost their car that they were sleeping in, and they're on the street. So it's a pretty disgraceful state of affairs. If we want to think differently about funding in New Zealand, and I've been sort of arguing this for a little while now and written a few things along these lines, including a co-authored piece with Peter and some others in the conversation last year that many of you may have seen. We've always had tax-based funding along with other funding streams, and there is a lack of clarity around much of this, as Peter was pointing out earlier, in terms of what's paid for, what the co-payments are, and so forth, and how funding moves through the system. We've had this population-based funding formula now for probably a generation, I guess, and it's far from ideal. It means that across the river north of Oamaru, the sort of the South Canterbury region gets 25% more funding per head of population in that region than the Otago region does, and so there are nuances around that formula that are far from ideal. And government, last government and this government have made absolutely no comments about the population-based funding formula. There was meant to be a review, as far as I was aware, but there's been no further comment on it. And so we can only imagine that what's going on there is as disorganised as things elsewhere across the system currently are. Let's bear in mind also that there is no perfect health funding method. Whichever way you go, there are going to be flaws, and that's because of, as Peter very eloquently pointed out, the complexities within healthcare systems. But if you are serious about access and equity, then only one method really would achieve those goals, and especially within the context of New Zealand, where we have this mixed delivery system of public and private, and that's a delivery system which, politically would be extremely difficult to try and unpick. You're specialists who work public and private, and there is when you talk to most people about this, they'll say actually it's really important because otherwise they'll go elsewhere if they can't generate the private income. And also in a capitalist, sort of market-oriented economy such as New Zealand, people should have a choice if they want to go private. So, there are really complex issues to be worked through in terms of the delivery system. So I come back to national health insurance as being a very important option that we need to be thinking seriously about if we are serious about equity, and in terms of how we plan for, say, the next 50 years of how we're going to go about funding healthcare in this country. So similar to ACC, you'll find this in the EU, especially Germany, and then it's the sort of the German model that made its way into Japan, South Korea, Taiwan. The goal is the same level of coverage and accessibility, regardless of your socioeconomic or health status or geographic area of location. It's often seen, and especially if you go to Germany, people talk about solidarity through the national health insurance that they have in Germany, and so it's something that binds people together, that they're all in this together. I think ACC could run this. I've spoken in the past with a former chair of ACC who has a background in corporate governance and financial trading and so forth. So, and he did the figures in the back of his head and said, "I would need about this much to set it up." So it was quite an astronomical sum of money. But after that, we would invest the money and ensure that we were able to, like ACC, although ACC again financially has been in a little bit of difficulty in recent times, would in theory run the national health insurance model. Very importantly, it's provider agnostic, and I think this is really critical in New Zealand. At the moment, the system is deeply, deeply inequitable. It's a scandal. It's nothing short of a national scandal that you will have people who are given morphine in the public sector for pain. They'll be going off to work on morphine. They will never get treated in the public sector. So these are things like gallstones, for example. Whereas if they have $10,000, they'll see the same surgeon in the private sector next week. Of course, they have to go to a GP for a referral to that surgeon. That GP receives a good portion, 50% or so of their income from the taxpayer. So that person who's on morphine stacking shelves in the supermarket, for example, is actually paying for the person who can go private and get their gallstones treated. So there's a lot of, when you unpick all of this, there's a lot of scandal that sits around our health system. And it's, it really is unacceptable. We don't talk openly enough about this. We hear the stories on the radio and on the television, but we don't have enough of a national conversation about the scandal that sits every day around people suffering. So a national health insurance is provider agnostic. The private sector could continue to grow and flourish, but people would be able to choose between public and private, so long as there is choice available. In theory, the private would no longer be just for the better off than the insured. So if we look at parts of the world with social insurance, closer to home, we've got Japan. They've long had a sort of a social insurance model, so they have about several hundred social insurance funds or providers, but they all offer exactly the same coverage. And then there are 3 different tiers of insurance in Japan. So you've got those that cover the public sector and large company employees, so your Fujitsus and Toyotas and so forth. And then you've got a managed plan for SMEs. And then you've got plans for local residents, for self-employed, pensioners and so forth, and the unemployed. And then the government in Japan subsidises the second and third tiers to ensure that there is equity of coverage across the system. There is a common fee schedule in Japan, which is very interesting. This is negotiated between the government, the insurance funds, and the medical profession on about a 3-yearly or so basis. So they sit around the table and they decide what's a reasonable amount of funding to be going for different kinds of services. And it means that the premiums will sometimes differ between tiers, and it's based on income. But there's a whole sort of art of balance, they call it, in Japan, where they go through and just ensure that things are going to function in a equitable and accessible manner for the population. It keeps costs down as well. This is what it looks like in conceptual terms in Japan. So you can see the 3 different tiers of insurance, and in the green there, different levels of government support going into the different tiers. It's all bound together by the fee schedule that then pays out to providers, public, private, non-government and so forth. Korea, yes, I see this is the penultimate version of the slides. I'm very sorry. I combined Korea and Japan. So we'll just look at Korea and then Korea and Taiwan, sorry. We'll just look at Korea and then I'll move on to conclude. Again, Korea, you've got a national health insurance funder, which is a kind of a government entity, independent of government. And they have had several hundred schemes in Korea that were combined pre-2000, or in the 2000 reforms. You will pay, in Korea is quite troubled, you'll often pay quite high fees for outpatient or hospital care, and there can be significant co-payments across the system. But again, like ACC, the funder just pays out on provider claims. There can be incentives put in place for certain services where there is a need to increase volume or intensity of services because of perhaps under provision. And they've had a DRG, or diagnostic related group payment system, since the late 1990s, which is a method to bundle together sort of cases of services, or a case of services and all of the different inputs into that service, so that you're not paying a fee for service for the various different specialists, hospital services and primary care that a patient might see item by item. So it's a kind of a global funding mechanism. Taiwan, again, same thing. I won't say too much about this other than that Taiwan is very, very similar to Korea. So it's payroll tax plus government funding, and covering a sort of a spectrum of services. Taiwan also includes dental and traditional Chinese medicine in their scheme as well. Just thinking about the point about dentistry in New Zealand. Just to conclude, it's time for a discussion. We've taken bold moves in the past in New Zealand when we created ACC. And it's time now for us to be similarly bold in New Zealand. I think we need a national conversation about this, and we probably need a commission set up to investigate national health insurance. We need a lot of analysis about how this might work. I think there is good opportunity to work with, for example, the iwi Māori partnership boards in terms of how we might configure a national health insurance model for New Zealand. And again, this is all about policy, and it's all about the decisions you take around how you design with purpose an arrangement. And so I think we could do this in New Zealand with our own flavour to it, and with the right level of analysis. We could get it right. It would require a lot of investment to get it started, because of course you're taking on all of the current health funding that's going into personal health services, hospitals, general practices, and so forth. Those services. So there'd be a lot of investment to get it started, but I think we could build it in a way that fits with who we are and what we want. So that's about it from me. I had a lovely picture of my university campus in the last slide, so I apologise for not having that in there for you to look at. If you don't know Bond University, I strongly recommend when you come to the Gold Coast. It's about 2 kilometres inland, and it's very, very different from the beach area, very, very different inland. It's a beautiful, beautiful part of the world. So I strongly recommend you come and visit us at Bond University. So thank you. That's enough from me. No, I am going to have to go in about 3 or 4 minutes.
No, thank you, Robin. Does anybody have any questions? Yes, down the back, Simon.
Thanks, Victor, and thanks for the presentation. It was very interesting. Those of us in the room that are old enough to remember when ACC was established will recall that the original Royal Commission recommended it as a two-stage process, starting with accidents and moving on to exactly what the professor is proposing now to cover general health services. Unfortunately, the implementation of the second phase was postponed so they could get ACC up and running. It was too much to do at once, and we know the rest. We never got around to the second stage, so this is a really interesting idea. It's not new, but it does deserve consideration, so thank you for bringing it forward again.
I wholeheartedly agree with that. Peter.
Yeah, kia ora. Thanks, Robin. Fantastic. I'm going to express my ignorance about how ACC works in terms of income derived from levies versus income driven by equity investments. Do you know what sort of fund would be required to allow New Zealand to operate its health system off income derived from equity investments? Or is it, presumably there would be levies or taxation which would feed into that fund on a day-by-day, year-by-year basis. But the fund itself would be the basis on which the system's funded.
That's right. So in theory, the level of tax that we pay would drop a little, because a significant portion of taxation income goes into healthcare. So in theory, your payroll tax would drop a little, and then you would have a levy, sort of hypothecated tax that you see in your payroll that's going out into the national health insurer, and then government would also provide a bit of funding into that. And then, yes, there would be investment, and this is how most of these funds globally work. The funds are used to invest. And again, if you look at Singapore, they're incredibly clever when it comes to how they fund public services. They have huge investment funds which generate a lot of income. They invest them domestically into their own infrastructure and services. And they're incredibly successful at it. I always think Singapore is a very, very interesting place to look at in terms of how you think about public policy. So I think there would need to be a quantum sum plus some shifts in the taxation system.
Just one other reflection. Thinking about back to Steve Keen's presentation, I mean, the assertion that we can't afford our public services, which is a common political assertion, does this actually alter that in any way? I mean, there are still fundamental issues about perceived affordability or otherwise, and in fact, Germany is now facing those public discussions as well. It doesn't actually get us out of those discussions, does it?
No, I don't think so. No. Yeah, I mean, the affordability question is a very unfortunate one, really. And I mean, I think, as you made earlier the point, Peter, healthcare is not a can we afford this? It's actually a matter of who you are as a society and what you invest in and how you support your people. To me, there are these questions around, should you invest $13 billion in roads or $9 billion in roads and $4 billion in healthcare? What's important to a society?
Well,
Thank you.
yeah, thank you, Robin. Thanks very much. I guess when you mention the I word, the insurance word, it always makes me very nervous. And I do think about what Steve Keen was saying, and that if we had a tax system that redistributed, or there's the distribution system at the point of money creation, and the tax system, which is the redistribution system, which is not working, neither of which are really working properly in this country from an equity perspective. And insurance, okay, it's a national insurance scheme, so I guess it's not set up to make obscene profits. It's set up to deliver a service, as I understand it.
Yes.
But, it's still a form of taxation, really, in a way. But anyway, we'll leave it there and we can argue about it over the airwaves. Thank you, Robin.
I better go. Thank you.
Yep.
And sorry to have to depart.
Yep,
There's
no worries.
happening over here. And work starts here at about 7 a.m. Campuses all go.
Oh, yeah. Thank you.
Thanks. Bye now. All the best for the rest of the day.
Yep, thank you very much. Okay, we'll take a 15-minute...
No, I'm all clear.
Okay, all right. Well, let's take 15 minutes back here at about 11 o'clock. pleasure to welcome Ian Powell. Ian was the former Executive Director of the Association of Salaried Medical Specialists, which is quite an important organisation in the scheme of New Zealand health. He's also a health system commentator and a blogger, and he writes a lot of columns in the Herald and so on. He's got a pretty good knowledge of our health system over time. And welcome, Ian. The floor's all yours.
Kia ora, and thank you very much for the opportunity. And just to avoid any confusion, I am not a doctor, although the impression that I am has been quite good for hotel upgrades and flight upgrades, inadvertently. But my focus is on how our health system can get out of the serious mess that it now finds itself in. And it's a quagmire, which is as a consequence of not of the system, but of poor political and health system leadership, particularly since the mid-2010s. Next slide, please. After providing some brief historical context, I then focus on the importance of developing the right culture and functions. I then discuss the form and structural changes that would enable this culture, would better enable this culture to and its functions. It includes looking as well at the role of local government, and I conclude with a brief comment about the importance of hope and its dependence on strategy. But before going any further, I've just got two initial observations that sit behind much of this presentation. The first is the expression, if you don't take the temperature, you won't take the fever, by one Samuel Sheen. And the second is a description expressed to me several years ago by an anaesthetist who graphically described her then chief executive as all
Something's gone wrong, Ian. I'm not sure if you can hear me. You've frozen a bit.
He's gone freezed.
I can hear you. Can you hear me?
Yeah, you just froze, so maybe you want to just go over that overview slide again.
Frozen again.
Oh, yep, frozen again. Well, we would have had an in-person conference, but that would have cost quite a bit of money. Always better in person. Not much we can do, is there? Oh, he can reboot. He can reboot his computer. It must be a Microsoft problem.
I'll tell a little story while we're waiting.
Well, can you use your microphone then? Go ahead.
I met this cousin over a cup of tea, and we had something in common. And that is, I've been busy trying to recruit more doctors to come back to Whakatane, because there was one that left a year ago because he'd fallen in love with my mokopuna. So he went to Auckland, and I'm disgusted. I did my best, and his parents came out from Scotland, who lived not far from this lady, and they came out, and we had dinner together out at the White Goose or something, and I did spend time trying to get them, and they want to come to New Zealand. I said, you better come to Whakatane.
Thank you for doing your bit. Ian, you're back on. Oops.
Okay, I'm not sure what happened there, but I was departed, so I came back in again. The historical context is that we started with hospital boards running public hospitals leaving the Department of Health with the responsibility for primary care and also population health. They lasted for 45 years before being incrementally replaced from 1983 by area health boards, which also included population health, and also over time it was expected, if had they continued, that they would become more involved in primary care. In 1993, area health boards were replaced by Crown Health Enterprises running public hospitals. They were required to function in a competitive internal market, so-called. In 2001, cooperation returned as the ethos behind the system, with the formation of DHBs responsible for hospital, primary and population healthcare for their geographically defined populations. Integration of community and hospital care was a central feature of their legislation, and they continued it until the replacement with Whataora Health New Zealand on 1 July 2022. Next slide, please. From 1938 to 1922, despite the structural changes, even in the 90s, the health system had been underpinned by a basic but profound principle called subsidiarity. When you reduce it to its critical essence, it means that things should be done locally except when they are done best centrally. It's the same principle that underpins the relationship between central government and local government in many countries, including here. The principle recognised that because healthcare is overwhelmingly provided locally, largely through general practices and local public hospitals, a significant level of decision-making should reside at this level. DHBs, as you know, continued for over 2 decades. Much of the first decade was characterised by a relatively hands-off role by central government. In relative terms, funding was on the right side of the ledger, with a particular emphasis on primary care. The rest of their lifespan was characterised by increasing central government control, with a changing leadership culture to reinforce this, along with relative underfunding. Next slide. When Labor became the government in 2017, it inherited a health system that was already in crisis and compounded by severe work shortages that had begun with medical specialists, but by then extended across all the health professional groups. Among the most critical factors behind this inherited crisis were the following. Overall health demand was rising in the early to mid 2010s. Acute care that cannot be deferred. Acute patient demand was increasing at a higher rate than population growth, which is behind the bed blocking and hospitals reporting 100% occupancy. Sorry about the dog in the background. And blocking is, and it was also the major reason behind the rising DHB deficits from the mid-2000s. The combination of increasing population, ageing, and increased poverty-related illnesses, and an absence of specific recruitment and retention strategies. Next slide, please. Setting up the review of the health and disability system led by Heather Simpson was a good move, but it did become a pretext for not addressing these inherited pressures. Her review affirmed, among many other things, that although reduced in number, I'm just going to close the door very quickly.
He's frozen again.
You've frozen again.
I'm back again, I think.
Yeah.
There was a serious lack of national cohesion in the Health Simpson, said the review, and the Health Ministry's functions of planning and funding should be transferred to a new national bureaucracy, Health New Zealand, which would sit, as Peter said, above the DHBs. Next slide. The Labor Party went into the 2020 general election campaign committed to implementing the principles of the Simpson Review. Continuing with DHBs was one such principle, but this radically changed with the announcement of a massive overturn of the health system by new Health Minister Andrew Little in April 2021, and it was to take effect within 15 months. This was also undertaken in the midst of a pandemic, which is a recipe for failure. Little's announcement included abandoning the pinch principle of subsidiarity that had underpinned our health system since '38 with the disestablishment of DHBs, radically changing the recommended role of Health New Zealand by requiring it to also assume operational responsibility for local healthcare delivery previously undertaken by the DHBs, and replacing Simpson's emphasis on cohesion with a de facto command and control culture delivered by structural change. This did not mean that prior to 2022, New Zealand health system, with both overt and covert powers of health ministers and central government, it was still one of the more centralised universal health systems internationally, including the NHS. However, the restructuring meant that the removal of the level of decision-making where it was most needed locally and meant its transfer upstairs. Next slide. By the time of the change of government following the 2023 election, the health system was in a much deeper and thicker mess than in 2017. In particular, many more hospitals were reporting 100% occupancy. In 2022, this occurred more than 600 times, roughly an average of about 2 hospitals daily. Severe workforce shortages had become entrenched. There was overcrowding in emergency departments that had worsened. A command and control vertical managerialism culture had emerged. There was a significant loss of operational expertise on how the health system works, particularly public hospitals, which became, because of the extra complexity and acuity they had to deal with, is where most things can go wrong and cost more. And Health New Zealand was operationally dysfunctional with continued internal restructuring, disempowerment at the local level and diffused accountabilities. The gap between it and its health professional workforce was much greater than between the latter and the former DHBs. Slide 9. Sorry, next slide. Regrettably, the neglect of the health system has continued under the current government, which has a very simplistic misdiagnosis, and that is, firstly, biggest crisis is Health New Zealand not keeping to budget. Second, the cause of the crisis is bloated bureaucracy, so-called back office functions, which we talked a little bit about earlier. And thirdly, the Messiah, aka Commissioner Lester Levy, will find the solutions. There are 2 main problems with this misdiagnosis. First, keeping to budget means cutting spending in order to achieve 1.4 billion savings in the current financial year, although that's been pushed out. The government argues this won't negatively affect the clinical frontline and patient care. However, it fails to recognise the centrality of the integrated relationship between the so-called back office functions and the clinical frontline. And there's no legitimate argument that the clinical frontline and patient healthcare have not been negatively affected as a consequence. Second, the priority issue facing the health system is reducing long waiting times for planned diagnosis and treatment. But that's what the government says, but hospital waiting times. But this isn't the priority issue. Instead, it's the increasing volume of acute hospital admissions and the increasing complexity of patients' conditions. That drives hospital bed blocking, which in turn drives emergency department overcrowding and increased waiting times for planned care. Next slide. The crux of the problem facing Aotearoa's health system today is the failure to recognise the need to reconcile 2 different health system complexities, the complexity of provision and the complexity of structures. The more these complexities are aligned, the better the health system performs and the better for patients and the health workforce. The less they are aligned, the more the counterfactual. The culture transformation is to first incorporate the abandoned principle of subsidiarity into the new Health New Zealand structure. This would involve recognition that decision-making processes should be closer to where healthcare is overwhelmingly provided, in communities and local 24/7 hospitals. That is where the more robust and sustainable decisions are able to be made. Linking to subsidiarity is the empowerment of health professionals across hospitals and communities. This intellectual capital is where the mastery of complexity and the introduction of sustainable innovation through continuous quality improvement is located. Health system complexity means continuous change. Today's silos were yesterday's innovation. Enable the use of complexity expertise in diagnosis and treatment for complex systems improvement. A third component of overriding cultural transformation should be the recognition of the social determinants, external social determinants of health, which more than anything else drive health demand and cost. While these determinants are more effectively dealt with through legislation and government policies, particularly in the case of healthcare access, the health system can play a mitigating role. Next slide. This culture shift can then trigger a series of functions, beginning with patient-centered care, which is about treating patients with dignity and respect, involving them in all decisions about their health. It is usually seen in the context of good clinical practice in the diagnosis and treatment of individual patients. However, it should also be elevated to the level of a health system function. That is, ensuring that there is the right workforce and technological capacities and capabilities to deliver patient-centered care for all. It is linked to the right of patients to timely access to quality healthcare. Another needed function, is strengthening the integration of healthcare between communities and care in communities and care in hospitals. This includes health pathways between communities and hospitals, as first developed in Canterbury DHB. The success of these pathways in that DHB was because they were clinically led and developed. If they hadn't been, they would have been reduced to mere rationing tools. This integrated function should also include developing local integrated care systems, including polyclinics providing a mix of community and non-acute hospital care. We need to shift from the divide between community and hospital care by recognising the value of structures that blend both within the constraint but within the constraint of what makes good clinical sense. This leads on to another function, which is distributed clinical leadership. Formal clinical leadership is important, those positions are, but they're only a small part of a much needed wider form of system leadership. That's empowered clinical leadership that is distributed amongst the whole of the health professional workforce. And that would enable so that the potential for systems improvement has enough oxygen to be realised. DHBs had a statutory responsibility for their geographically defined populations. The Simpson Review proposed strengthening this through the establishment of community-based localities. With the abolition of DHBs and the subsequent diminishment and then forgetting of localities, there is now a vacuum. It is therefore important to enhance the role of local government in healthcare access. Local government cannot replace the functions of cannot replace the former responsibility of the DHBs, particularly in provision, but it can provide advocacy and voice. We are already seeing this. Examples are in councils in Dunedin, Selwyn, Kapiti, where I live, and of course Whakatane. Functions such as patient-centered care, empowerment and distributed leadership cannot be achieved until the severe current workforce shortages crisis is addressed. The health system is plagued by widespread shortages across all the occupational groups, each with their own distinctive labour markets. Workforce development and well-being should be a function with specific targeted strategies developed as a consequence. Next slide. And at this point, but not before, form and structure should come into play. They are what you wrap around culture and functions in order to better enable them and to align the complexities of healthcare provision and structures. The last thing the health system needs now is a major restructuring. It's destabilising. The health workforce and the public have gone through enough, but by transforming the leadership culture, there is potential for reversing the downward slide of the health system towards further decline. This begins with returning to some of the key features of the Simpson Review that were abandoned by the former government. It includes a cultural shift from command and control, to cohesion. It means being consistent with, but taking further the direction that the former Health Minister, Shane Reti, was hoping to go. When the final report of the Simpson Review was released in 2020, I was sceptical of some aspects. I considered that it lacked sufficient explanation to justify some of its recommendations, such as localities, reduced number of DHBs, and I disagree with Peter in that respect, and dividing the Health Ministry into two to create Health New Zealand. In respect of the third recommendation, my view was that the problem was the leadership culture of the ministry. The focus should have been on resolving that problem rather than creating a new bureaucracy. But this is 2025, not 2020. Getting ahead requires recognising that the structures we now have rather than what we used to have. Neither the health workforce nor the public deserve to be put through another destabilising system overturn. So it is a question of therefore incorporating the above-mentioned transformation and functions into the existing structure by adaptation, not restructuring. The four regions of Health New Zealand, which now have their own Deputy Chief Executive, should be empowered to have similar levels of decision-making authority as the former DHBs had. Local government could also have a positive role in giving voice to community needs at this regional level. This would mean transferring much of the responsibilities to the regional level. The national leadership of Health New Zealand should be consequently downsized to providing national cohesion and certain functions that are best conducted at national rather than regional level. The immediate benefit would be more improving collaboration between public hospitals. With the right systems, culture and function, significant clinical and fiscal gains can be made here. However, in my view, more gains can be made in the relationship between primary and other community-based healthcare on the one hand and local 24/7 acute hospitals in the other. The success of the former Canterbury DHB's clinically developed and led health pathways is testimony to this, including bending the curve of increasing acute hospital admissions. But there would need to be an appropriate level of decision-making at this local or district level to make it meaningful. Perhaps localities as originally envisaged by the Simpson Review, but without the consequential disestablishment of primary care organisations which have proven to be the structural glue holding primary care together today, perhaps also based on links to local government at this level. Final slide. No matter how high the level of despair is within and about the health system, we need hope. But as the American linguist and public intellectual Noam Chomsky once said, if you don't have hope, you can't have strategy. And my hope is that what I have outlined provides a basis for such a strategy. Thank you.
Thank you, Ian. I have a question. I didn't realise when I invited you that you were on an entity called the Kapiti Coast Health Advisory Group, which runs out of council. And I'm quite interested in how that operates, and I'm contemplating putting something on the table that's similar. So how did that develop?
It initially began as something established by volunteers in the local community, and this was before my time. As to look at ways of improving access to healthcare, basically on the Kapiti Coast. Over time, it then became a committee that advised the mayor at the time, not the current mayor, the previous mayor, but then became, quite recently, in the last 18 months or so, an advisory committee to the council. It's quite free-ranging in terms of what it does, and it has a number of subgroups on for transport. We have serious transportation issues, healthcare access, and that's a subgroup that I lead, population health, and I know I've missed something else out there too. And everybody on it is volunteers. One of the things that we have done and I've been the lead author for it. And I'm not sure whether it winged its way to through the email to you last night, Victor, or if it hasn't, I'll send it. There's something called a compelling case, which is to establish an existing health care centre on the coast in Parapara Umu that provides a limited range of services, and there happens to be an NGO general practice located as tenants within it, but it includes the district health nurses and some limited number of outpatient clinics, mainly allied health professionals and nurses. To expand that over time into becoming what could hands on heart be a polyclinic, providing a range of community-based healthcare services and less complex non-acute hospital services, and also 24/7 urgent care. And the council is set up to consider this. We're going through community engagement at the moment, but the council will be considering it as a recommendation, possibly as early as early May, late May.
So what
volunteers, all with different experiences in the health system, even includes a former head of Treasury.
Right. I guess I was asking what problem was there that this group was seeking to address? Well,
healthcare access.
The motivation.
We're quite a distance away from Wellington Public Hospital, particularly the ED. We believe that a number of patients who present to the ED treated and discharged rather than admitted into the hospital, many of those could have their access improved. It's basically seeking more health services to be provided by Health New Zealand in its facility on the coast because of issues of access and also health conditions as well. We've got good data from our PHO which shows that 15 health conditions that are assessed by, provided the data comes from the general practices, it shows that 14 of those were more disadvantaged per capita than the Greater Wellington area. So it's providing more services on the coast, both lower level hospital and community based, integrating them more and providing, we hope, a bit of a hub for innovation.
Yeah, thank you, Ian. Councillor Isles wants to ask a question.
Thank you, Ian. Andrew Isles, a councillor here in Whakatane District Council. Just wondering, with regards to that service that's run through the Kapiti Council, is it facilitated by them or is it in any way funded, ratepayer funded?
It's resourced by the council. We report to the council has two main committees, and one of them is called Social Sustainability. The other is I think Finance and Strategy. I think, and we report to to that. We can do our own initiatives as well, as long as they don't conflict with the council, and they don't. And the chair of the Social Sustainability Committee is a regular attendee of our meetings, and also another councillor, a ward councillor, also has the delegated responsibility of being there as well. As it happens, two other councillors as well, by choice, come to most of the meetings. So there's a bit of looseness, but it is part of the formal structure.
None of the members of the panel are remunerated, though, are they?
No.
No. Okay.
And not complaining.
Yep. Okay. Thank you, Ian. Any other questions of Ian? Down the end of the room, Sheila?
Where is the finance for this coming from?
There's no finance required.
I'm talking about this.
For what?
I'm talking about to Ian Powell.
Sorry?
Yeah, no, that's what I'm...
Where is the finance for setting up this whole organisation that you've done come from? It can't all be voluntary.
Yes, I understood it's all voluntary. Is that right, Ian?
The members of the advisory group, yes, it is. The proposal we are making for expanding the services at the local facility and to eventually become a polyclinic over time, would not involve increasing rates, because the council would not be a provider. It would be an advocate.
Yep, thank you, Ian. Any other questions?
Kia ora,
Rachel?
Ian. Thank you. Your neck of the woods is probably very similar to ours in terms of a lot of holistic care as well. We have funded services such as primary and secondary care, but we've got lots of miri, romi, sound healing, all sorts of other holistic services here in Whakatane and down Kapiti Coastways as well. In your conversations in terms of whether it's your model of care or your care pathways knowledge, how do you see that there's an opportunity to weave in some of these preventative health measures to address things like ED and bed blockages, waiting times?
Well, we've looked at the data on to give an example, on ED admission presentations in Wellington, in Wellington Hospital, and it shows that if we had a 24/7 acute service integrated into the facility, we could reduce that number quite considerably, and that would reduce the pressure on the ED. We also have a high dependence in terms of people going to the how they present, the referral source. The biggest factor is the ambulance service compared with the other admissions from outside Kapiti and the Greater Wellington area. And by reducing that, we can actually free up the use of paramedics for what they themselves are developing as a model of care, of extended care and diversion care, not confined to care in the ambulance itself. And so I think that these things are all integrated, and we think that we can actually not only benefit the population of the coast if we get our way, but also benefit the wider health system in a very integrated way.
Thank you, Ian. Any final questions for Ian before we let him go? No? Thanks very much, Ian, and thank you for the advocacy you do. Keep up the good work.
Thanks very much.
Thank you. The next speaker is Terry Taylor. He's a specialist medical laboratory scientist with over 30 years of frontline experience at the Dunedin Hospital Laboratory, and as I commented in my talk, pathology laboratories are critical. I guess we saw them come into their own during the COVID pandemic, and I guess there will be other pandemics, so we should make sure that they're tooled up and ready to go. Thank you, Terry.
Kia ora, Victor. I presume you guys can see my slide up there?
Yes, we can. Yes.
Brilliant. Look, thanks for, number one, for the invite and obviously being part of this. And it's actually probably very apt to where we've come to now with some of the other talks that have already happened here. I'm going to give a bit more, it's probably a bit more a confronting assessment of where things are in our health system at the moment, with using our pathology sector as an example, was something that I'm very familiar with. I am a long-serving scientist, but also a long-serving part of the professional leadership of pathology in New Zealand. So I've been involved in the leadership since 2008. And, things, to be honest, for the first 12 or 13 years, just smouldered along until...
Hang on, Terry. Just a minute, Terry.
You've muted yourself, Terry.
Yeah, looks like you've muted yourself.
How dare I do that? But I'm back on board, and you can see the slide here of what happened to us in 2020 when the pandemic sort of arrived on our shores. That was a very interesting time for us as scientists and technicians in New Zealand, because generally we were behind the scenes. No one really knew a lot about us. And suddenly we were thrust into not only the political limelight, health leadership limelight, but also the media limelight. And it was a very, very difficult and confronting time. But it also, in a way, harnessed an opportunity for us to get out into the open and actually explain what was really happening inside our laboratories and to something that was so critical to the health system. I've just muted myself again. Sorry, team. As we move into the so as we move into our future here and we see what started to happen with the pandemic, we're beginning to see some of the major things that actually went on. I think, can you still hear me?
Yep.
Oh, you can, good. Sorry, just had a bit of a technical glitch there. But anyway, and people will be well aware when the Omicron variant hit us, just what really the impact was starting to have on our laboratories. And we could see what started to emerge was that we were starting to get a capacity issue. We were starting to get a workforce issue. And that actually prompted numerous reviews that went on at that time in the post-immediate laboratories being overrun time to look into the nitty-gritty of what was going on in our laboratories. And we, as a professional body, actually got quite involved in that. And one of the things that we started to do was to look inside our profession, what was really going on, because not many people really knew what was happening. And from that, we ended up going to Parliament in 2022 and presenting a pretty confronting document, I have to say, to the government on what our predictions were for the sustainability of the pathology sector in New Zealand. And this really has just carried on since then. So there was some stark warnings back in 2022 that, to be honest, have come to total fruition now in 2020, late 24 and now into 25. And of course, build into that the issues that we had with infrastructure and the like. I mean, whoever thought of building a tertiary hospital and not including a pathology lab for a start was just some of the unbelievable stuff that we was having to deal with in the background. And then we started to see the smouldering of a workforce under immense pressure that was struggling in their workforce wellbeing, how they were looked after. And then the only thing left for a lot of these people, which is a very difficult decision to make, is to make very public stands about the situations that were starting to emerge inside our laboratories. And in a very confronting way, we started to see that with the strike action and the industrial action that's really dogged our profession for the past 18 months. And in the meantime, we were seeing some other inherent issues start to come to the fore across our anatomical pathology provision across the country as well, with the accreditation issues kicking in due to workforce shortages, due to the environment not being what it should be. And then a few health and safety issues that started to raise their ugly face, and questions starting to get asked like, why is there no national accountability for what's going on with this sector? How come it seems to be like the Wild West of the health system? And then as time's gone on, we've started to see the major fiscal issues raise their head in our profession. And so we're starting to see the big companies that are involved in our pathology sector struggling fiscally. And when they struggle fiscally, trust me, those of us on the front line struggle with them. And you know things are in trouble when the pathologists get involved. So when the pathologists start talking about how bad things are, trust me, they are getting very bad. And when they're putting things out in the media saying that they fear a sector collapse, trust me, it means it's not far away if we continue on with the way we're going. And obviously you've heard from Ian already. Ian's written many articles about the situation with laboratories. Rob Campbell, former chair of Health New Zealand, also has. We've already touched on the massive leadership changes and the issues that they bring with them. You can imagine what it's like for a professional leader. Every time there's a change in leadership means that people like me have to front up and explain everything about our sector once again, give them all the documentation, because every new leader has to be informed about what's actually going on under their watch. And a bit like everything, when you're a bit more hidden and behind the scenes, you tend to get forgotten about. And those of you that have been pretty aware of recent times will note that we had a large proportion of our medical laboratory workers in New Zealand under industrial action about 3 weeks ago, which effectively shut down most primary care and most public hospitals. None of them wanted to do this, but they feel they've been pushed into a corner that no one's listening, no one's taking notice, and nothing's changing. So just a bit of background about the pathology sector. I'm sure most people would have very little knowledge of what actually goes on. We're around about a 4,000 workforce, and we do 220,000 odd tests per day, with those figures increasing per annum about between 4 and 6%. Very similar to what was being discussed about our fellow medics. It takes nearly 10 years to become a specialist medical laboratory scientist like me. I'm a cancer diagnostic scientist. You do not learn that overnight. It takes years and years and years. And people like me, when they walk out the door, they take institutional knowledge that simply cannot be replaced. You've already found out from what Victor was talking about. The majority of the health decisions are based on your pathology testing. All your cancer diagnostics pass us through the laboratory at some stage. The other factor is that all pathology funding is publicly funded for medical reasons. So that means all your hospital, public hospital and private hospital, incidentally, and community pathology is funded publicly. That's our budget. So, you know, not much shy of 700 million and about 2.6% of the Vote Health budget. That's pretty standard worldwide, incidentally. And as has been explained earlier, around about 65% of that figure's a little bit lower because I think, Victor, you didn't include the likes of the New Zealand Blood Service and also ESR in some of those figures. But around about 65% of your publicly funded health services are provided, our pathology services are provided by private providers, and nearly half of the hospitals, our public hospitals, now have private lab contractors within them. And this is just a visible breakdown of it, and some of this is a bit outdated because APHG has now morphed into what's known as Awanui, and obviously the district health boards have now morphed into Health New Zealand. But you can see that in New Zealand we do have a major monopoly provider of private services in Awanui, or APHG as it was there, and the other percentages. And in your local region there, of course, you have PathLab, which again is a private laboratory but publicly funded. And just on that, so to do with our workforce, we have the lowest amount of Māori and Pacifica employed within our laboratories, and we have a significantly aged current workforce. So we know leadership is key, and that's been discussed right through this forum up until now. But we are especially absent in the pathology sector. We just do not, or have not had, any operational leadership within any of the health leadership for the entire time that I've been involved in the profession, unlike what happens in just about every other Western country in the world. So we are lumped into this group called Allied Health Scientific and Technical, but in saying that, we still have never had a scientist involved in that leadership. So once again, we're missing out on that. And just to show the importance of that, in line with that, there's never been any national governance strategy or direction for publicly funded pathology in New Zealand. It's been, yes, regionally delivered, but there's been no coordination nationally, and it has really fallen by default in the hands of the providers. And effectively, that means our direction is not really determined by health leadership in the first instance. And as I've just said there's been very little involvement from the clinical workforce in the planning and the outsourcing, and in fact anything to do with pathology service provision, because of just the way it's been outsourced. In a way, it's really not the way that we should have been envisaging this to happen. So in line with that, we have great difficulty getting data nationally on what the true situation inside our pathology sector is. When you've been hidden behind closed doors and there's a lot of competitive posturing between the different providers, they're very reluctant to give up data. And Health New Zealand's not much different between their public labs because we have no oversight. And this is the hardest thing that I've found in my time of dealing with health advocacy and professional leadership, is trying to get it through to people that, yes, we need doctors and nurses, but doctors and nurses cannot do their job if they do not have the tools in front of them to provide them with the diagnosis and the direction for the healthcare that's going to be provided. So realistically, it almost feels like we have to fight twice as hard as everyone else for half as much. So if you're talking about inequities in health, I think pathology is a classic example of almost feeling like we're the bit like the bottom feeders of the health service. So just a bit about the professional body, and it's no different than any other professional body. We're not a union, so we don't do the negotiations, but we certainly provide all of those other support services, including advice, and we have the excellence across our profession. So we're represented in every laboratory in New Zealand, and that gives us that national coverage, but it also gives us that expert opinion from what's happening exactly on the ground. And that allows us to provide the roles that we do to try and get the message out there. We obviously are very much involved with policy and strategy, but the reality is, for all of the times that I have been directly involved in that over the past 10 to 15 years, nothing has really changed because it never gets instigated because of the fragmentation that we actually have within our pathology sector in New Zealand. The other thing we do is provide qualifications and advice, obviously, is a big part of it, and we work closely with the universities in getting our new graduates into the profession. And so we are the largest stakeholder in the pathology sector. Not that you'd think it or believe it sometimes, because we've had so little influence in actually determining where our sector goes. Now, just to bring a little bit of history in here, so the first merger to private, in other words, outsourcing, was done in Dunedin and Invercargill, but like everything, it seems to originate in Dunedin. And incidentally, it was signed off by Pete Hodgson, who was the Labour Minister of Health at that time, and also signed off by Richard Thompson, who was the chairman of the Otago District Board at that time. And it started a period where DHBs, because they took over the funding for their pathology, saw this as a great idea to get rid of or make a bit of saving, sign off their pathology services and think nothing of it and think everything will be under control. And what that led to is, amongst the private market, was the competition between them to get the contracts. So ultimately there was a lot of cost cutting, undercutting to get those contracts so they'd have continuity within the services. You can see where this is all heading, can't you? So within those contracts, you as consumers of our services would be horrified to know where your patient samples end up in New Zealand. They don't go to the nearest place that can do the work. They go to whoever's got the contractual arrangement to perform that work in New Zealand. And it most certainly is not always in the patient's best interest. It's certainly not in our professional or service interests either. So now we're in a bit of a quandary because there's been very little oversight from DHBs and Health New Zealand. Basically now we're seeing the bonnet being opened and realising that the engine has basically got a few major issues going on inside it, and how on earth do we start to think about fixing it? Well, the pandemic was great because it got us in the room and in rooms that we've never been in before, so at least we're able to start this process. But you can see all of the things here. You can just feel the perfect storm starting to emerge with all of these issues suddenly coming into the open under a tight fiscal environment that we're in, and a difficult health situation and health and social situation. So there's always that expectation now that more and more is put on less and less. That is incredibly difficult for our health professionals to deal with on the ground. And in saying that, when you get your experienced staff that have had enough and walk out the door, the obvious situation emerges where you've lost that expertise and you end up having a lot of our specialist services being plugged in the meantime to get through things, and it's really making the rest of us struggle. Despite us having a shortage of need for, or we need more scientists into the profession, because of the constraints in the system at the moment, many of our graduates simply don't have a position to go into, which is unbelievable. It's untenable that that's allowed to happen currently. And just on top of that, our students pay for everything. There's nothing comes back their way. And in line with that, we have great difficulty with our career progression and the intent to actually recognise the expertise we have within the sector. It's really turning into a major issue that we've got. So we really do need to start thinking differently about how we provide our pathology services across the country. That's pretty obvious. If you bring in any external providers, of course they're businesses, they're required to make a surplus, but that's public money. Just think of it that way. So because the contracts were often short term, realistically there was no need to have long-term planning in your strategies. So everything is leading to the situation that we're seeing ourselves now. And then of course COVID provided the perfect golden handshake for our laboratory sector, which I don't disagree with, because it was certainly something that needed to happen to fund on top of our laboratory contracts. But over that 20-month period, nearly $500 million was injected into the New Zealand pathology sector for PCR testing. And unfortunately, we on the ground did not see a lot of that, and still don't see a lot of that investment from that. And that is a real concern. And then we've added on another complexity to our pathology system, because the Health New Zealand Equity Agreement was agreed to in 2023. And remembering that pathology is 80% female, that meant that we ended up with a serious issue in the sector, because this emerged. All of the Health New Zealand employees in the public labs got around about a 20% pay increase, plus went up progression criteria. That did not apply to the private sector, and they did not stump up with any of the money for that, which I have sympathy for them, because they did get caught on the hop as that. But it means we've got a two-tiered system at the moment. So this is not news to anybody, because it's across all of the professions, but we know about the hiring freezes and the ghost job vacancies. We've been left with a fragmented pathology environment. We've got major issues starting to emerge across the regions, of which you are one of them, and no doubt you are feeling that in your region there. Imagine the likes of the Invercargills, the Nelsons, the Marlboroughs, the Wairarapas as well, the Wanganuis. Everyone's going through the same pathology issues now, and now it's starting to emerge in our big hospitals. We have Dunedin Hospital and Wellington Hospital are both run by a private entity, as is Tauranga, as is Palmerston North. So we're starting to see Rotorua as well in your region. So we're starting to see these things kick in. And then, of course, as I said before, we've seen a significant drop in revenue from our biggest provider, Awanui. So now we know we've got a problem, and it's starting to manifest with the workforce, massive discontent in the workforce on what's going on. Lots of letters bouncing back and forward. But the reoccurring theme, no action. So we are just seeing so many people walk out. We have so many good scientists and technicians that don't work in medical laboratory science in New Zealand. Ultimately, they will come back if we put the carrot out in front of them, but they're not there at the moment. So we have major recruiting issues. People do not want to come and work in a low-paid job with the immense pressure that they're facing at the moment. So Australia is a bloody good option for our practitioners at the moment. And again, because of what we've seen over the years with everything being minimised and no one bothering to look under the bonnet, until people like the NZIMLS, myself and other advocates have actually started to open the doors and say, this is not working. We are facing a massive crisis here. So a lot of the laboratory contracts around New Zealand that have been outsourced are simply being rolled over because there's been no real direction. We know that there's a governance proposal, a national governance proposal underway with Health New Zealand and the government, but there's been no progress and certainly no announcement. So I'd like to say we're getting the interest that we need to now. I wrote a very strongly worded letter to Lester Levy back in December, basically explaining what was about to happen to the New Zealand health system if we carried on with the situation within our pathology labs, and it has not got any better. So, but there is a way out, and I do have hope. I remain optimistic that we can get there, but it needs to happen now. So we need to look at our pathology sector under a veil like this. We need our national governance. So we need a long-term plan. As everyone has said, strong clinical leadership involvement, regional delivery. It's a reoccurring theme. So maybe a formation of a service entity similar to the New Zealand Blood Service, who, incidentally, Lester Levy was the CEO of early after its formation. And then Te Ahu o Te Kahu, the Cancer Control Agency, is another clinical example of this. There are going to have to be some big and tough decisions. And I think that's the problem at the moment. There seems to be a real risk-adverse culture to making a decision that will actually make a difference. So we need to look at it like this. Every pathology dollar that we have for pathology needs to be spent on pathology in the current environment. So that needs to be a priority. We need to decide what tests and services are funded and what isn't. I heard that obviously came up earlier from Robin. We need to make those decisions. What are we going to look at and what aren't we going to look at? In other words, are we going to start demanding that the private hospitals, for example, start funding their own pathology services? These are big decisions that need to be nutted out in a clinical environment. And we need to have specialist centres around New Zealand as well. And where are they going to be? They may not be in all the areas that people want them to be in. We definitely need the leadership. The leadership is critical. It's got to be non-vested and strong with clout, because this is going to take a lot of work and a lot of things that not everyone's going to agree with to get things moving in the long term. And as I've said, it needs to be a service model built on publicly funded services that are there for the right reasons. And again, in line with that, if you pay your staff and look after them, they will stay and they will come back. And we need to be looking in that direction right now. We've got a workforce that's ready to go. So there's no issues at our end. If someone makes some big decisions to move, we will move with them. Yeah, we don't want to be looking at things like this anymore. I don't like doing this, neither do the staff on the ground. We would rather not be seen and not having to protest that things are not good. And do you want this as your new future for the health system? No one wants that. We want this. This is how we want to be promoted, and this is how we want to be remembered within the health system as a well-versed, well-resourced and specialist workforce that we actually are. And I go back to a couple of things that happened. Probably the worst day of my professional life was when we got overrun, and back there on the 23rd of the 2nd, 2022, and I had to front the national news and tell what it was like. It was an unbelievable time. We had practitioners phoning me in tears thinking they'd let the country down because they'd got overrun. For goodness sake, I think the country or the health leadership and government leadership let them down. We are very close to that situation now. And I think this is a massive warning sign for everyone that people need to stand up for the services, particularly your regional services that you have. You probably don't even know what is happening within some of your service provision in the health sector. And I think as local, particularly local government representatives, you really have an obligation to be looking into that. And it's great to see you standing up for your local region up there. I really do call on other regions in New Zealand to do the same and ask the hard questions, because we are here to serve you. It's not the other way around. And sometimes I think some of our health providers think it's their prerogative that's important, not yours. So on that note, I'll just leave it there, I think, and apologise for all my technical misfits at the start. But, you know, it is what it is when I'm not there. Like was said by Victor, I would love to be there because that's definitely the way we like to operate, being around people.
Thank you, Terry. I guess for decades now we've been locked in this public versus private polemic. You know, is private really more efficient? Is it better? You've got three private providers of publicly funded pathology. So these are multinational companies that they bring in their lab and their equipment and experience or whatever. They get a government contract. They get paid directly for the government on a per sample basis, presumably. Is that how it works?
No. I'm going to correct you there, Victor.
Yep. Just
no.
wondering.
That's so why the DHBs back in their day, in their wisdom, contracted out at a fixed price was to simply stop that burgeoning out of control per specimen cost that was happening out in the community. So no, they are actually contracted on a fixed basis, hence the bidding between the different providers for the services.
All right, so if we went fully public, would we have the workforce and the skills to do it?
With a dramatic change or actually introduction of true pathology leadership, my view is yes. As a public service entity, we've got a perfect example in the New Zealand Blood Service, who, when they became national back in 1998, I was in the laboratories at that time and they were part of us in those days. Everyone said, no, that won't work. Well, I'd like to say that I think New Zealand Blood Service is a really good example of how you can do it and how you can do it properly. We have a workforce ready to go now.
Okay, just to follow up, if your service breaks down, doctors or GPs or clinicians do not get the diagnoses they need. Why are they not screaming out?
They kind of are, but they're kind of not. I think one of the issues is you don't know what you don't know. And that, in a way, is a facet of ourselves because we haven't been public enough. And often, look, it's very difficult to, I just put it this way. You can imagine what it's someone like me. I'm not here speaking on behalf of my employer. I'm here speaking as a professional leader. How difficult do you think it is for someone within those laboratories or courageous to speak up about what's really happening behind the scenes? It's incredibly difficult in this environment to do that. And I think they are now, and you will see and hear a lot more in the media. And I know you've had a lot of media in your area about it. But that's the reality of the situation. I don't think everyone really understands just how perilous a situation we are in.
Yep, thank you for that. Any questions from the floor? Yeah, you can chip in if you want.
I was going to suggest that the question should be after I've spoken, because Terry's a fellow scientist and we can both have a go at answering questions. Otherwise, we're a wee bit out of time, that's all.
Terry will be online anyway. Are there any questions from the floor for Terry? No?
I have a question.
Peter?
Thanks, Terry. Wonderful presentation. In the current, given the nature of the current government and its philosophical leanings, the chances of renationalising the pathology services seem remote to me.
Yeah.
Therefore, adequate funding is the next best response to the current situation. But if you were to give them three priority actions to take, what would they be? Adequate funding, and what would the other two be?
Okay, I've thought about this a lot. and I get asked that question a lot. Firstly, true clinical national governance and strategy of our pathology sector. Number one, we have everyone's doing their own thing. It's incredibly fragmented. Number one, you do that, you will end up finding savings because there's a lot of duplication in the system. So that is number one. Number two, your big hospitals, your big public hospital labs that are currently outsourced. I would imagine there should be some discussions going on about at least getting back control of your big tertiary hospitals. So that's number two. Number three, yes, funding is huge, but should you be throwing funding at a broken model that you know is going to eat money? So my key takeaway from that would be investing in our future a bit more, and that goes for training and education. We are about to hit a massive issue as far as with our retirement of most of our people like me. When we walk away, there's nothing underneath us at the moment. And that our BMed Labs, our scientist training courses, are incredibly under-resourced at the moment and fighting unbelievable battles that you probably are aware of, Peter, but I just cannot believe the lack of funding that we get for that sort of thing. I've had many a battle with the TEC on that. So that would be my three approaches. I don't have an issue with private providers. I'll just make that clear here. I don't see a problem having a PPP for some of our community services, as long as there's control. At the moment, there's no control. You're saying, here you go and do the work. You operate under a different strategy than the rest of us. Oh dear, you're in the crap. You're coming back for more money, but we don't know anything about why you need more money. So there you go. That's how I would do it, Peter.
Thank you, Terry. That was really helpful.
I mean, just to you, Peter, you said that there's no chance, given the present government's ideology about reverting back to a national system, and yet I ask myself all the time, how do they prove their case? I mean, we've had decades of this idea that private is better than public, and yet all we have are crises upon crises. And if you want to look at success, look over at China, at what they've achieved, where the state takes a primary role in funding and supporting things. I mean, they're just beating the West hands down in all areas of technology. Surely we're you know, if I want to do something in council, I'd have to write a business case and I'd have to prove my case. Yet there's no case being proven for any of this. But anyway, that's my frustration boiling over there. Sorry.
Yeah. Look, I agree. But your question was, how do they prove their case? They don't.
Yeah, that's right.
There is no pressure on them to do so. The political one-liners they're on a loop play with no evidential base at all. Often, sometimes there is, but usually not. So look, the politics of this are pretty clear. And the reason I said what I said was that that the inclination of the current health system leaders, including the PM, to opt for market-based or private solutions is very strong, I would have thought. And Terry, you say that the big tertiary hospitals should think very carefully about re-internalising their own pathology services. Even that, I would have thought, is a long shot in the current political climate. I'm totally in agreement with you, and I've lived through the transition. I've watched it all.
There's an election next year.
Yes, indeed, Sandy, there is.
Okay, guys. I'm just wondering how you lead.
Observation.
Yes.
Yeah. Well, I agree completely with what Terry and Peter have said. But just in terms of Terry's comments about a public-private partnership, my advice would be careful what you ask for, because one of the things about a PPP, it's not a partnership in terms of equal partners. The private provider will only get involved if they are if they can make a decent profit out of it, they would only get involved, or mainly get involved, if it has to be a greenfield rather than a green site rather than a brown site. In other words, not building upon existing infrastructure. And they will have a significant control and influence over the design of the capabilities of the eventual outcome. And PPPs, certainly based on the NHS experience, end up costing a lot more down the track. They come back to bite you. Just an observation.
Well, I'd also poo-poo PPPs. I was in Australia when the fashion of PPPs came along. I mean, for the private partner, if that's the right word, for them it's a de-risking strategy. So, you know, the state takes the loss. And didn't we see it over in, what was it, the roadway there called, the motorway into Wellington.
The expressway, to the custody.
There was another example of a PPP gone wrong, and yet we still keep talking about PPPs as if they're manna from heaven. So I don't know, I agree with you, Ian. Thanks for the caution on that one. If there are no other questions, we'll move on to the last speaker of the day. Well, the last speaker of the day is Alexander Sandy Milne, who is something of a taonga in this district. I've known Sandy for 5 years now. What he achieved back in the day was really quite outstanding. He took on health authorities that didn't want to listen. They didn't want to see evidence either, which comes to some of the points we've been making here. But he made them listen, and he's still around at 90, almost 91. He's always been vehemently opposed to privatisation, especially in the diagnostic laboratory area or pathology laboratory area. And he's a microbiologist by training.
Hematology, blood transfusion, and microbiology.
Anyway, it's my pleasure to introduce Sandy Milne. He doesn't need any slides apparently, so.
Right. I'm okay.
The floor is yours.
Look, I'm starting by telling you that I've listened to Terry. Where's he gone? Can we see Terry somehow?
He doesn't want to be seen, but he's there.
He doesn't want to be seen. What a shame. Come back, stay there. I have to congratulate you, Terry. That was great. Okay? Keep it up. I wish you were my neighbour. The other thing to tell you is that what you've said in the last half hour or more has screwed up my paper because I'm not going to cover what you've said already. But I'll mention my perspective as a smaller hospital principal scientist who's been retired for a long time, but I haven't gone to sleep yet. The other thing to say is I nearly went to sleep earlier this morning because I'm trying to get over COVID, which I got last month, and I'm so weary. Then I thought, gosh, if other speakers carry on too long, I better cut my stuff. So last night I cut my presentation short, and I made a wee bit of room because I won't cover the things you mentioned. However, and the other point is that when I showed Professor, in fact, he never admits he's a professor, this guy. When I showed our chairman what I was planning to say, he said, "Oh, that's a case study." And I said, no, it's not a case study. But in fact, it is. Because the service that I really worry about most is microbiology, or diagnosing infectious diseases. And that's a sad case. The way it's been run in the last 37 years in this area is a disgrace. If I was running it, I'd be ashamed of myself. But they get away with it because there's no proper audit or checkup or consultation with the patients, afterwards. Outcome evaluation is the words they use. No proper consultation with the patients or the doctors about how they would go on, and did they have to have repeat antibiotics and so on. So I'm going to proceed through my amended, even as you wrote, Terry, I'm proceeding now through my amended lead points. Firstly, I became aware of the private lab problem about 59 years ago, and I gave a talk to a commission which was in Auckland. I went from Thames to Auckland. I was in Thames for 2 years. I went to Thames to Auckland and pointed out that this is not fair. These private guys are going around, as they were, going around touting tests that needn't be done, that were expensive, and touting special, what they called executive checkups, annual checkups involving testing that wasn't needed because they weren't sick. This kind of waste. So you have to forgive me if I ramble a bit. That's not my intention. It's just that I'm a wee bit weary. Anyway, back to the point. I started complaining about the private labs when I was up in Auckland. And what they do at a time like that is they employ a guy like me, and I was offered jobs to keep me quiet. In the private sector, it happened. It's happened to me twice. Probably happened to you, Terry, has it? Anyway, I moved to Whakatane in 1967, and at that time, we were a full community laboratory. We did the inpatient work, the outpatient work, the family doctors' work, and also the public health work, like water testing and so on. I managed to assemble a good team. And now, when I say this kind of thing later on in my talk, don't think I'm bullshitting. I assembled a good team, and we turned out to be the best team in the country for a hospital like ours, or for any hospital. At that time we got workload unit to present workload unit reports to the Ministry of Health, or the department as it was known at that time, and we always came up 120%. We had a system called the Canadian workload units. Do they still use that, Terry? No, Canadian workload units, you used to measure the output, right? And we came out top. They didn't believe us. I just had a good team who worked hard, and we didn't look at the clock too much. The next thing that happened was the ministry didn't believe us, so what they did was they sent a guy called Rod Kennedy from Auckland. He was the chief technologist there, and he came down and checked us out, and we went back to the ministry or the department saying, "Oh, it's true. They are top right now." So about our productivity, I don't know about our quality, but I think the quality was all right, or good. We did get tested for quality as well. I was doing all this without a pathologist in this area. We didn't have a pathologist. I got on fine without them. In fact, nowadays they're almost overrated, because I can ring a pathologist in Aberdeen or New York. I've got some friends over there, and get free advice in 5 minutes notice. Easier than calling somebody out of bed at 2 a.m. in Taronga, which is our centre. I'm going to speed up forward to tell you the first pathologist came, and he didn't have enough work, so he went off and he worked in the Portici as a GP. And then later on, we got another pathologist. Meantime, I picked up on this, and this is important, folks. The reason that I became famous and got my gong was that we did all the work. We could see what was happening in the community. Hepatitis B we didn't know it was hepatitis B. All we knew it was yellow eyeballs and dark brown pee. It's even in kiddies. Now, this was, somebody should have picked it up, but you couldn't because testing was done in private labs, didn't talk to each other. So that's why it's important to keep your finger on the pulse. You've got to have control of all the laboratory services in your area. It's in my opinion. Anyway, the next pathologist to come was a doctor, or better not mention his name, a doctor from England, and then we heard of plans about the mid-80s, plans to privatise the laboratory service. So I said to this guy, I consulted my staff and said to this pathologist, hey, this is a great chance. Why don't we form a community private laboratory? All the profits go back into the community. I had consulted my staff. They said, great idea, let's do it. I went back to the pathologist and said, let's do this. And he said, oh, I'm not very happy about this. I said, why? Oh, well, it'll upset my Taronga colleagues. Fact. So anyway, I asked him to go to Australia, and he did. He did. It didn't stay there long. And fast forward now, it was MedLab in those days. MedLab took over the pathology services for all the GPs in our area, from Portakey to Whakatane, Kaura, all these places. And from then on, specimens for microbiology in particular, all of them, hematology, microbiology, chemistry, and so on, they all went past Whakatane, through Whakatane, another 90 kilometres, is it, to Taronga. And none of them got there on time. None of them got there early. And, of course, what happened was Whakatane Hospital Laboratory lost half of its workload, or more than half of its workload. Now, not many businesses can handle that. So we went from being best in the country to probably worst in the country for productivity and efficiency. And nobody would listen. I wasn't the only person speaking out, but that's what it was. Whakatane was taken over by subterfuge, in my view. Lies were told, and people, even our doctors or mayors, were all manipulated, and we lost a lot of good staff, which is, I think we lost about 3 or 4 or 5 staff. These are scientists. It was a disgrace. So the senior medical officers, SMOs at the hospital, were not happy about this, and they complained, but they didn't know how to organise. Well, I knew how to organise and deal with the ministry because of my work with hepatitis B. They were very difficult. People who should have been doing the work were obstructing me from doing the work. Anyway, the DHBs, the senior medical officers, SMOs from the hospital, that's 30 of them, asked me to help them organise a protest, and I did. In fact, I helped them compose a memorandum to the District Health Board, because I knew how to do that kind of thing. And they all signed it, except for one guy, which comes to the title of my presentation, the change management, managing change, how they did it. They had I'm certain this is the case because I was told by a doctor. There was one doctor at the hospital who didn't sign it. I've got the signatures here. One didn't sign it, and I asked the surgeons and others who were collaborating with me, "What's going on here?" They said, "Well, we think he's there to smooth things out and make it easy for the changes. This happened. And it was, I'm sure, he's got an office here. This is what the doctors were saying. He's a doctor, he's got an office here, and we don't know what he does. Can you imagine running a business like that? Anyway, that's happened. That was the truth. The lab scientist who followed, who was running the lab at the time, because I was running the hepatitis research, was a guy called Russell Cole. Far better scientist. I don't know if anybody knows his head. But he was a better scientist than I was, but not so good at battling. And he got kicked down the road. Do you know what that means? He got sacked. And then all the specimens for microbiology, which is the most important specialty, that were all sent to Tauranga to join that's been happening to all that's hospital patients going to Tauranga, joining all the GP specimens that were, every one of them arrived there hours too late. And there are guidelines for specimen delivery. And I'm in touch with a woman, an American woman called Professor Ellen Jo Barron, who was on the first teams who set the international standards, which applied in New Zealand. And none of our specimens, I think 98% of our specimens missed. Some specimens arrived a day or two late. In fact, the same lab has got a notice to various doctors in the community. We will accept a specimen for microbiology up to 3 or 72 hours late. Now, I don't know, if you've got a disease, an infection, the last thing you want is a specimen to sit around somewhere for up to 70 days. That's a disgrace, isn't it? And in fact, the Wakatani Beacon sent this is 13 years ago, sent a letter to the DHB asking, would you please tell us, backed by some kind of evidence, how long it takes to transfer specimens such as feces and urine, which must be analysed as soon as possible after provision from a patient, to from Wakatani to Tauranga, or Portuguese to Tauranga, and Te Kaha to Tauranga. And the reply they got was, now listen, I would like your response. The premise of this question is incorrect. That is, samples must be analysed as soon as possible. Okay. Feces and urine specimens which cannot be cultured properly need to be preserved in fridges or somewhere. Once refrigerated, the specimen is viable for analysis by culture for up to 48 hours. This allows ample time for transportation. What have they forgotten? They've forgotten the patient, haven't they? The patient's out there is probably going to get an antibiotic for a bug that has not been identified. In fact, Terry Taylor, who's listening to this, knows that half of the respiratory antibiotics for respiratory infections are not justified. In fact, they do more harm than good. And that's happening in communities like this, ours, New Zealand wide. I'm going to fast forward because, I know, it's already here. Anyway, this is what's happening. The introduction of, or the takeover or hijacking of our clinical laboratory services, especially the microbiology ones, which are the ones I worry about, was hijacked by stealth. Lies were told, and I can prove it. And here's my point. I've no chance of covering what I would like to tell you in such a short time. It's been cut back, and I've listened to the chairman telling me don't make it too long. But we really need to do something. And Terry, you have a duty to motivate your lab workers to rise up and protest. Who's that joker there? Somebody. Anyway, so I haven't even mentioned the doctors who were on our side or my side during the campaign that they asked me to lead. And if you like numbers, now believe me, I've sent 12,000 emails out, 12,000 in the last 12 years. It's enough. And I've had encouraging letters, or 700 encouraging letters from doctors. And I've visited centres of excellence in Britain and done all this at my expense. But I've got it all written down in my huge amount of notes. I've got something to confirm everything I've told you. But I just had to finish. Firstly, that point I made about the specimens can be stored for up to 3 days. Does anybody think, raise your hand if you think that's sensible? If you think it's sensible. Okay, that's my way of saying, don't bother raising your hand, just the other way around. But the other thing to let you know is, while all this was going on, the doctors asked me, because I was working in Vietnam at that time, the doctors here, the local doctors in the Whakatane Postgraduate Medical Association, asked them to give a talk about my work in Vietnam. And somehow the District Health Board, I don't mind saying this, the CEO was a guy called Phil Camish in Tauranga. And he sent me, now listen, I got this by mistake. They kept sending me things by mistake. But Helen, Matthew, Michelle, this is a letter he'd sent, an email he'd sent to 3 of his Whakatane workers in different agencies. In Milne's latest email outpourings, he claimed to have been invited to speak to doctors, I assume about microbiology transport. Well, I've told you it wasn't, it was about Vietnam. Any ideas, this is the point, any ideas which doctors, now that's sinister to me. What was he they used to send the heavies around to the doctors. That's enough for the now. I'll provide you with a follow-up if you want. I'll give you my email address now, and that'll be it. Sandy, SANDY .MILNE at xtra.co.nz. You know.
Thank you very much, Sandy.
That's it.
Thank you very much.
I've cut my children.
We're going to break for 30 minutes for lunch.
Oh, forgot to show this.
And we've got Don Richards, who's from Positive Money. He'll speak for 10 minutes.
Yeah.
He's going to reinforce some of what Steve King was saying, except for in language we could probably all understand. And then 10 minutes of Prabani Wood, who is it's a pre-recorded interview, and you're going to get snippets of it. The full interview will be on our website, so it's worth listening to, because she's an actual GP. She's worked in that sector, and so it's good to have the voice of the GPs here as well.
Last comment. This is from the Whakatane Beacon in 1988, in which one of the private pathologists says, community laboratory, the private lab, is not competing with the hospital services. They weren't planning to compete, they were planning to take over, even if it took a while.
Sandy's a warrior. Thank you, Sandy. Lunchtime, folks. Okay, welcome back everybody. There's two brief talks. The first gentleman will be Don Richards. He heads an outfit called Positive Money, and as the name implies, it's about money for good. And it will follow some of what Steve Keane was saying, because what he was trying to tell you is that there are problems with our banking system. It's all geared up. It's not a level playing field, and Positive Money is really much in that thing. But I'm sure that Don can do it in a way that's more understandable than probably Steve, who's got all that mathematical rigor behind him. So Don, welcome. If you can unload, that'd be great.
Okay. Sorry. Yeah, good afternoon, and thank you for the opportunity to speak to you today. My name is Don Richards, and while I live in Whakatane, I'm currently in Tauranga. And as Victor says, I'm the national spokesperson for Positive Money New Zealand, which is an enterprise dedicated to having a banking system that works for us all, not just the select few. And you're quite right, you did hear from Steve Keane today, and I won't be having any slides, no graphs, nothing like that. And he was talking about the government's ability to run a deficit. And in fact, he says it's the way to go. But we have a slightly different approach here at Positive Money, and we say that our Reserve Bank should create money to finance infrastructure projects. Now, we only need to look back a couple of years to 2020 and 2021, when the Reserve Bank created $55 billion and provided it to the banking and financial institutions as a way of providing stimulus to the banks. So we're not saying give the banks more money. No, we're saying the Reserve Bank should create money for infrastructure and provide it to the local government funding authority or other institutions to allow them to finance the build. So we've done this before. In 1930, the then Labour government provided millions of pounds for the construction of state houses and also to enable farmers to sell their produce in Great Britain. More recently, the Bank of Canada, the Central Bank of Canada, provided funds for the construction of highways, schools, hospitals, and other essential infrastructure. And that sort of spending is called direct monetary finance. And so there is a fear that it might be inflationary, but inflation actually relates to the quantity of money, not its source. So provided there is a physical ability to deliver the infrastructure projects such as labour, materials, equipment, there will be no inflation impact. So with the use of direct monetary financing, that will actually free up tax monies that would otherwise be spent on infrastructure. So that freed up money could provide us with a world-class health system. With the wise application of funding, we will have a health system that serves society equitably and without barriers to access, which emphasise prevention rather than cure, and is something that all New Zealanders have a right to aspire to. So that's my presentation. Do you have any questions?
Any questions for Don? Actually, yep.
Would that have an effect on the actual, our exchange rate type thing? You know, if there's more money and it's just been made, it's, you know, it's sort of a bit like the social credit thing back in the 70s, 60s, 70s, that sort of thing of, you know, just print more money. Wouldn't that have an
Well,
effect?
Well, private banks currently print money, put it into circulation, billions of dollars for house purchases, and it has little or no impact on our exchange rate. So we're not talking about that level of expenditure. We're talking, maybe, 15 billion a year for infrastructure payments. So I don't think that would have an impact on our exchange rate.
I mean, in a fiat money-based system, all money's created. That's what fiat means. It means let it come into existence. So private banks create money when they make a loan. That's what Steve Keane was telling you. The Reserve Bank can create money, and I use the $70 billion. Don, maybe I got that from. I don't know where I got that from, but most of that money went to private banks, as Don says, through a program called Funding for Lending. In other words, they fund the private banks to lend the money. Well, who does a private bank want to lend to? They want to lend to real estate. And so what have we got? We've got a real estate bubble. Surprise, surprise. But if it had gone to infrastructure, it wouldn't have been inflationary, because that would just provide jobs, and you would end up with something that's worth nothing, which is the money, something that's actually worth something, which is the infrastructure. I think it's that simple. It's actually so simple that people don't believe it. But you just got a talk at the beginning of the day by Steve Keane, who put all the mathematical rigour behind it, and his mission in life is to debunk economics, mainstream economics. And in fact, his first book is called Debunking Economics. And I think he's right, and I think Don's right. But our masters, I've got the government minister telling me there is no money. Well, your New Zealand dollars is your money. In fact, the bank creates it for you. Well, the Reserve Bank is your bank. I don't know. Anyway. Yeah. Good idea, Don. Let's do it.
Yeah, well, look, we're going down to Parliament next week to talk to the Finance and Expenditure Committee regarding local waters done well. And we're saying that council and rates are already way too high.
Yep.
And it's time for you to use Plan B. And we can do the same thing for the health system as well.
All major infrastructure that people need, the commons, should be paid for by the state, which is all of us.
Exactly.
Thank you. That's excellent.
Well, thanks, Don. Are there any other questions for Don? They gave a good presentation at the mayoral forum I was at, talking about how to fund infrastructure via this mechanism of the Reserve Bank. And I don't think anyone believes any of it. I mean, even if you tell people the government created $70 billion of new money, people don't believe it, because it goes against everything that they've had drummed into them from the time that they're young. But anyway, Steve Keane told you, I'm not an economist, but Keane is, and he's pretty good. I don't think there's too many better, but anyway.
Thinking outside the square too.
Sure.
Infrastructure, how wide, it's a wide term. What are you actually talking about as infrastructure?
Well, I would count things like, Don, that's for you, sorry.
Yeah, sure. We're talking about roads, schools, hospitals, airports, physical items on the ground. We're not asking the government to create money to pay for wages and salaries or whatever, because that would have an impact on wage negotiations. Imagine if you went into a wage round knowing that the Reserve Bank simply could create more money to pay for your wages. We'd have a blowout there. So we just want to make it for infrastructure, and only the infrastructure where there are resources available and there is that's basically it.
I think that's
consider the People's Republic of China. What country on this planet has developed the most infrastructure in the last 40 years? It's them. Who owns their banks? They do. The people do. Who owns our banks? We don't.
The government does.
The government.
No.
The dictatorship there.
Yeah, I know, but because the government should control the system of money, not private entities.
Yeah.
That's what I believe anyway, but they've been successful.
Yeah.
There's no doubt about that. You know, what took us 15 years over in Tauranga, those overpasses, they'd have done it in 15 days or 150 days, something like that. Yeah, why are we failing? Why have we got an infrastructure crisis? Why has the United States got an infrastructure crisis? Because whatever we're doing, it's not working.
No.
Anyway, that's my rant. I'm sounding like
No, I think it's
a
quite
preacher.
right.
Thank you, Don.
Thank you.
Can
Good
I?
luck in Wellington. Oh,
Thank you.
another question?
Yes, please. To a simpleton like, to a simpleton like me, I think back to the 70s when social credit was rife, and I wonder if it's so simple, so easy, why doesn't the government just do it and fund everything? What's the problem? Are we affecting our overseas exchange if you just create money?
Don?
He's right, yeah.
Well, it depends what you're creating money for. Oh, I'll try and answer. What you're creating it for. If you're creating it for things like a housing bubble, well, what have you just achieved? You've made life impossible for 30%. Susan was asking Don, if it's so easy to create money, why doesn't the government just create all of the money to do everything?
Well, that's a very good question. And a lot of people say it's going to be inflationary. And that closes down the narrative. But if it's used for infrastructure and there is available resource, then it's not inflationary. The problem is the narrative is being controlled by vested interests who want to keep it this way. So you won't hear any banks saying, we're creating money out of thin air and then lending it to you at compounding interest. No, they'll say, we're here to help, we're all that. So vested interests want to keep a lid on this, but it has been done in the past, it can be done in the future.
Yeah.
Yeah, it was done after 1929, after the Great Depression.
I noted, Don, that you said that it's for infrastructure provided the resources are available, and I think it is cautionary to emphasise that provided resources are available. Otherwise, all you're doing is creating a construction boom, making a lot of very rich construction contracts, and which does flow down to wages and material prices as well. So there needs to be some boundaries around how that's applied, but yes, other than that.
Absolutely.
Actually, Steve Keen's talk, he gave you the full mathematical and accounting rigour behind it all.
Yeah.
And so that's what all those graphs that we're doing, maxing out, we're proving that it's not inflationary.
No.
Yeah.
I mean, he
I don't-
built that code.
I
for
don't
that.
disagree, but too much too soon.
Oh yeah, no, well,
I mean,
yeah.
we've all lived through artificially created bubbles. It can happen.
Yeah.
All right. Well, another question at the back there.
I don't mind asking a question, Don. So is what you're purporting to do, is that similar to what the Public Works Department would have been and done, decades ago when they were funded from central government to do all of those public works? Can you hear me?
I couldn't hear that question, sorry.
Yes, Anita.
Hi, Don. Tracy Livingston here. Sorry about that. Is what you're purporting with the medical system similar to what the Public Works Department would have been doing decades ago, and we lost that?
Ministry.
Yeah, it's similar. It is similar. But I mean, it doesn't necessarily have to be Public Works. It can be any construction company can step up to the plate and we'll pay them using money created through the Reserve Bank.
Yeah.
Yeah, but that's inflation, right?
Actually, the founders of Positive Money in the UK have written a book on, what is it called, Don? What is Money, or something like that? Yeah.
Yes.
And they've got a very good documentary on it, which goes through it step by step. Okay, so the last talk of the day is Dr. Prabani Wood. She'll give a little bit of a background on herself, but she was set up a practice in from scratch that actually had about 21 staff. She's got a master's in public health as well as being a medical practitioner. And she's now working for the New Zealand Initiative. And before you all go gaga on that one, she's hardly what you would call extremely right-wing. But anyway, I'll introduce you to Prabani Wood. I interviewed her. The interview went on for an hour, but you're going to get 11 minutes of it. The full interview will be placed on the website. It's, well, thank you, Prabani.
No sound. No sound.
I've been a GP for 15 years. So I'm a GP. I did all my GP training in New Zealand. So I've been a GP for 15 years, and I achieved my fellowship in 2016. I also, in 2015, opened a new practice from scratch, so which is quite unusual. So I built a practice from scratch, which grew from 0 patients in 2015 to 9,000 patients.
9,000 patients, gosh.
We might have to restart that one, Louise.
And I undertook a master's in public health from Auckland University. And as you can tell from my accent, I'm one of the 40% of overseas trained GPs in New Zealand. I grew up in the UK, having been born in Sri Lanka, but grew up in the UK and did my undergrad medical training at Oxford University.
Yeah, no, that's pretty impressive background you've got. So we're here really to discuss the predicament of our health system, and sometimes I have to ask myself, but I mean, from where I sit, it looks like our health system is in a severe crisis, the likes of which it hasn't seen. So do you think that would be an accurate portrayal of our health system at the moment?
Yeah, we use the word crisis, dire, and emergency. I mean, I think all those words apply. And it's sad because these things didn't happen overnight. The warning signs have been there for many, many years and have been ignored, not just by this government, but by successive governments. So that's what's disappointing.
Yeah.
You spent 8 years in general practice, so did you see a decline in standards over that time? You witnessed it on that time scale?
Yes. So I believe you don't have general practice, you don't have the full remit and the value add of specialist GPs if you aren't able to also have continuity of care with your patients. So that was the fundamental principle on which my practice was based. Each year, despite the practice growing and, in terms of the business side of things should have been easier, each year was getting harder because of workforce attrition and fewer people wanting to be GPs. Because people don't realise how hard the job is. Lots of evidence to show that being a GP is the most complex role in medicine. It's not often seen that way, though, by some others in health and policymakers. So people are leaving because of worsening conditions, and that means fewer people are wanting to come into it as well. So each year that was a battle. It was getting harder and harder. And then on top of that, it was system issues too. So IT, we have such, it's unbelievable the IT systems that we have in this country. It's mind-boggling how bad they are. And each day there are thousands of interactions with patients. where you're literally flying blind because you don't have access to important information. We're still relying on fax machines. So how dire, if you want to use the word again, diet, that's how dire it is.
We've definitely got a crisis, the problem that we've got insufficient workforce. How do we fix that?
Well, I know people get tired of people asking for more money, but actually there is no way around it. We do need more money to cover the costs of the care that is needed for to service the needs of our patients. And then how we use that money is important as well. If we could build the health system around primary care and have that as the most important part of the health system, then we would be doing things the right way. But it's easy when we have 3-year election cycles. Lots of governments just focus on getting voted back in, don't they? So it's very easy to build a shiny new hospital board or a whole hospital and think that likely you will get votes from that. But that's not really the hospitals are the ambulance generally at the bottom of the cliff. People who are working in the community who aren't as visible but who are there, they're the ones that really holding the health system together. But over the last, especially 20 years, I think they've just been squeezed dry, really, and there's no more to give. So you're right in terms of, you leave medical school, you have a debt and you want to service that debt, but how you work, your working environment, the terms and conditions under which you work are also really important, aren't they? And when you feel that you can't provide the service you need to for your patients, you feel every day that you're failing, it starts weighing down on you. And especially for GPs, because we have that ongoing relationship with our patients. I think that's what's really, making people struggle. And people talk about, GPs are just closing their books. They're not closing their books because they want to. They're closing their books because there aren't enough people to look after the patients that they currently have in a safe way and without diminishing the quality of care. So it's not like, some people are saying, just make the GPs work harder. It's not that we're working as hard as we possibly can, but there's not enough resources and not enough people to do the work.
I guess you've heard Robin Gauld summarise the Social Security Act of 1938, which promised New Zealanders a universal, availability of healthcare. The same care for everybody without any barriers to access, and a system that wasn't fractionated, and a system that prioritised prevention. Do you think we've ever had any of that?
I think we did. Looking at the statistics, if you look at life expectancy between New Zealand Pākehā and New Zealand Māori, the lines nearly met. They came quite close. Probably, I think the best figures were in the 60s and 70s. And then, this country, they call it Rogernomics, don't we, in the 1980s. All those things changed. Everything started to be privatised. And that's when the disparities slowly started to reoccur.
Could you talk about the equity issue a bit more?
Yeah, so, Victor, it's great that you said you feel you're in charge of your health. It's up to you to deal with your health. But many people don't have even that basic right. If you're born in a house that's, overcrowded and damp, and half the adults there are unemployed, you keep getting sick, so you hardly attend school. You get glue ear, which doesn't get treated, so then you have issues with your hearing and then can't learn at school. You're already starting way behind anyone else, and that's just basic things that we're not getting right. So someone's health is going to be very low on the priority when they can't afford to feed themselves or their family, right? Or heat their home or keep it dry. I think there's basic things that we are lacking. 1 in 4 children in this country still live below the poverty line. That's an alarming enough statistic. So there's your equity. The fact that we still have rheumatic fever in this country, where I'd never seen it till I came here. We read about it in textbooks, even school sores, impetigo, so that the skin infections you get. I'd never seen that, and we still get that here. And that's to do with overcrowding and poor housing and poor nutrition. So it's basic things. It's not just health. Obviously, health is just a part of the picture. It's all those social determinants that work against a huge proportion of our population, which make, it's worse. Anything that you look at, life expectancy, chronic diseases, diabetes, heart disease, they're worse than any parameter you want to measure. If you want to look at privatization, essentially general practice is privatized, right? You can see what's happening already. You already know what's going on. In 1938 Social Security Act, general practice opted out. So it's been privatized since then. So that's always been tricky. You're trying to manage a business as well as provide care, which I truly believe primary care especially should be universally accessible. And you're seeing what happens when it's privatized. You can see what's going on.
But by definition, our system is two-tiered. I mean, by definition, there's just no way of arguing anything else. You've got those that can afford these premiums of up to $1,000, and the rest of us who can't. You know what I mean?
The thing that worries me is that because we don't have the staff. Just because you opt to go privately, if you can afford to, it doesn't mean you're then lessening the burden in the public system. In fact, you're possibly increasing it. That's the other problem, isn't it? So there's plenty of well-meaning people who are paying, using their money, but also feeling, oh well, at least it means I'm freeing up a bed for someone else. It doesn't actually work that way.
If there was one thing you could do to sort of result in an improvement, what would it be? One wish.
If it's just money, just put the money into primary care. There would be even more short-term pain in the hospital system, but actually, it wouldn't take long for it to turn around and for the hospital system to then improve. If that was one thing, it was literally just take the money you're thinking you're putting into the hospital and divert it into primary care.
Prabani Wood, thank you very much for your Dr. Prabani, your input to what we're doing here, and thank you for doing what you do. And we'll catch up another time, shall we?
Yeah, we'll do. Take care.
I should have mentioned that Prabani's dad actually lives in the district, and he was the obstetrician and gynecologist at Whakatane Hospital for more than 20 years. But he's now 72 and retired, so, or something like that, 74 maybe. Well, that's the end of the talk, so we're on a round table discussion now, so I'm not going to do any talking. You guys can do it. Does anyone want to say anything? I mean, this is as one of the speakers said today, that this is the start of a discussion. There needs to be a national discussion about what Kiwis want and what they're prepared to, and how they're prepared to fund it, I guess. Yes?
I'd love to speak. Thank you.
Sure.
I'm not going to yell in the microphone this time.
Well, I did a bit of that myself.
Okay. Hi. I'm going to, I don't know, stand. This is awkward. Thank you so much for organising this. I remember looking at, it was Radio NZ, is that better?
You can sit over here.
Seeing it on Radio New Zealand advertised, and I thought, this is going to be amazing, and it really was. But I'm also somewhat disappointed that there's not a whole auditorium full of people here, because I think this is one of the very, very important conversations that we need to be having at the moment. I'm coming in from a alternative, complementary and alternative care background. So I've been looking at the system and thinking it's going to fail for quite a long time. And so when I saw someone talking about it failing, oh, okay, sorry, I can't figure out where to stand. Okay, I'm going to sit. Leave that there.
Well, there's a spare seat here. Yeah,
Right.
if they want.
That's a bit better, sorry. So I come in from a holistic or alternative complementary medicine background, and also from a political background as well. So I knew Don through the positive money, social credit, all of those kind of things. So I've been looking at this for years, going, why aren't we funding healthcare through a positive money social credit system, which we used to do. So, and the legislation is still there to do it. So it's not like, it's going to take years to write the legislation to make it happen. But what most people, the doctor before was talking about Maori healthcare statistics, and what most people don't know is over 100 years ago, Maori were literally the healthiest people on the planet. So this is all documented, and how they did it is documented. It was documented in the 1930s. And so we don't have to reinvent the wheel. And so what we're doing at the moment with our disease management system is disease management. We're actually not doing what we need to do to take pressure off the system by having a healthy population. So I think it's something like 25% of people in New Zealand at the moment are considered disabled in some way or other. That's a quarter of our population. That's terrifying. How can you run a country when 25% of your population is carrying a disability? Yeah. So I would love to have input into the future about how we actually take pressure off the system and how complementary and alternative medical people and health coaches and things like that can help take pressure off the system so that the medical professionals and the, pathologists and what have you can do their job better and with less pressure. Because as an osteopath, I'm seeing the repeats who come out of hospital going, I'm still in pain. I'm still dysfunctional, but I'm not acute anymore. I'm chronic. So people will go chronic, acute, back and forth. So what I find I can do, and my colleagues, is actually heal the person so they're not ending up back in the medical system all the time. So yeah, maybe they end up with an acute problem, but actually a lot of that stuff can be managed in an alternative way. So I just think it's really important to bring in the complementary and alternative medicines into this conversation, because without us, you're always going to struggle. Yeah. So thanks for the opportunity to talk about that. Cheers.
Thank you. I see Malcolm Mulholland online, and Malcolm, I've read a bit of his stuff, and he advocates in this space. Would that be fair enough, Malcolm? Would you like to say a few words?
Yeah, just kia ora koutou. He mihi nui kia koutou. Ko waiau ka maka mahonto koingoa no nā tukahanu ne te iwi. Tēnā rā koutou katoa. Just to say that thanks for inviting me. Good to see a familiar face with Terry advocating as passionately as he does for the pathology sector. And it's been really great to hear the other speakers as well as a part of this forum. My role is as chair of Patient Voice Aotearoa. Patient Voice Aotearoa started about 6 years ago following the diagnosis of my late wife Wiki with advanced breast cancer. At that point in time, we were focused on getting a drug funded, and then that spiraled into many other drugs getting funded. But over, I would say, the last year to two, we've been approached by a number of patients about problems to do with the health system. And when we strip back and look at the problems, ultimately we land on systemic failures. So these are through no fault of clinicians or nurses, etc. It's just a system failure. But it's becoming very commonplace, and that's what scares the heck out of me and keeps me awake at night. And so we've just been going around and talking to different communities. We started last year with a declaration called the Buller Declaration on the State of the New Zealand Health System. It began in Buller. The reason being is because that's where I grew up. My father still lives there. He's 84 years old, lives in the middle of nowhere, and was transferred from Buller Hospital to Greymouth Hospital one weekend. So I received a call, and I couldn't quite figure out why they were shifting every patient out of Buller. But I was to learn that they were short-staffed, in particular with nurses. So they upped sticks and went to Greymouth, which I just found very bizarre. And then following that, there was a high-profile case of a man who died, who had presented to the RED effectively, and subsequently died. And the serious incident review that was conducted on that death basically came to the conclusion that this doctor, who was on staff that evening when the man presented, was overworked, overstressed, and just simply did not have the capacity to deal with patients. So when you start to see things like that happening, it becomes really scary. And so the community reached out, and we started this declaration. The declaration says 5 things. It says, 1, the New Zealand health system is in a state of crisis. 2, the government must act urgently. 3, rural, Māori and low-income people are disproportionately affected. 4, the government must meet its obligations under Te Tiriti and protect Māori health through working with iwi and hapu. And 5, additional resources are urgently needed to train, recruit and retain more nurses, doctors and specialists. So it's quite simplistic. It doesn't provide solutions as such. It just is a list of instructions that the community wants the government to deliver on. It's deliberately worded in that way because we also realise and recognise that not everybody will be conversant with our health system. So we've tried to keep it at that very high level. And next week we are starting with our North Island Roadshow with the declaration. So working with the salaried medical specialists, the Nurses Union, the Royal College of GPs and the Rural Health Network, we're going on the road, talking to different communities, holding public meetings and talking about the state of New Zealand healthcare. The outcome that we are wanting from those meetings is, 1, for people to sign the declaration, and there'll be versions of the declaration that'll be left in different communities. So think about it in terms of, I guess, the most easiest example to compare it to is like the Treaty of Waitangi. So Porirua will have its copy, Whakatane will have its copy, so on and so forth. And we'll leave it there for those communities to sign. And then the idea is that we bring everybody together later in the year in November and deliver that declaration to Parliament. So it's something that people can feel that they're a part of and that they're actually doing something to try and help address the crisis. We are in Whakatane. We're yet to finalise details, but we're looking to get there on Thursday, April 10, from 1 to 2 for the public hui. So I'll definitely let you know more about that. But it's probably enough from me at this point. Just wonderful to be a part of this forum and hear what the other speakers had to say.
Do you know about Art Nahil's Hikoi for Health, I think he calls it? He's got himself a van all painted up, all sorts of colours, and he'll be driving around the country. So, I mean, it seems that there's some grassroots movements around, right? People trying to do things.
Yeah, so we've connected up with Art. We're going to connect up for at least 2 of those meetings. He's kind of working his way south. I'm going north, so somewhere in the middle. There'll be a couple of occasions there for us to be both speaking publicly about what those issues are. So that's wonderful to see. I think the other thing too that I will just mention is that where we see the failures is very much at a patient level. So we'll have, for example, a patient contact us, and I'll give you some real life examples. Prolapsed uterus, been waiting 18 months, no update from the hospital about surgery. We here at Mid Central, I have irritable bowel syndrome. I won't go into the full details, but I'm at high risk of bowel cancer. I'm on the surveillance colonoscopy list. Those colonoscopies have been paused by the local hospital because there's no capacity to do them. So we've been very public around that. There are about 850 patients affected by that decision.
Yeah.
And then we've dug a little bit deeper when it comes to just mid-central, just as an example. And I know that this isn't unique just to mid-central, but in speaking with staff, there's a chronic work shortage in the general medical registrars. There's only 3. Neurology, there's only 1. Our stroke service is in risk of being shut down. Radiologists, we only have 3. We should have 15. And there's not enough psychiatrists. So that's just mid-central as an example. But I'm sure, I know you yourself have had examples around obstetrics, etc., and gynecology. It's just quite horrific.
A lot of people are leaving because they're not getting paid enough.
Thank you, Malcolm. Yes.
Hi. Hi, I'm Prue Rangi, and I'm a member of Whakatane Action Group, and I was also part of the organising committee for the Hikoi for Health that we did just over a week ago. I was speaking to a couple of quite senior nurses yesterday, and I said I was coming to this, and they said there's a 6-month wait for people in Whakatane to get to see a gynaecologist for hysterectomies, and there are women around who are in desperate need for that. So it's not just our obstetricians at the moment with our maternity care. Also, they said there's been 2 babies now born on the way to Tauranga Hospital, and also they're having a pretty horrific time. The staff over in Tauranga are totally overworked. They do not have the time to spend with the extra babies and mums and babies that are going over there. They have also had to request for staff from Whakatane to go over to help them in the maternity because they're having to reciprocate, and that's not working out because they have got the nursing staff here anyway. Also, another thing I was told was there was meant to be an MRI scanner for Whakatane Hospital.
Right.
Was meant to be here in November 24. There's still no mention of when that is going to happen. Apparently, it's being put in by a private company. They are at the moment having to work out a deal because they're going to have to lease some part of the hospital ground because it's going to be a private company on government land, and so all this red tape and mucking around, and meanwhile everybody in this area from Portaka right through has to go to Tauranga if they want an MRI scan. We are being downgraded, and we're going to end up just like the hospital in Taupo in the end. We're going to end up just a glorified A&E where you're assessed and shovelled off to either Waikato or Rotorua, as that's what happens in Taupo. So you can just see what's happening here. They're desperately short of, she said, they need 6 obstetricians are needed in Whakatane. That's besides the gynaecologist. So that was sort of her. And she's also hoping that the new manager for Whakatane Hospital is not just filling a seat, and that she will be able to manage. Okay, that's my...
Did you say 6 obstetricians needed here?
Yep, that's
what
wrong. She said.
Goodness me. It's wrong.
Because they have to be on call 24/7. So she said it's not that you need 6 on duty, but by the time you've got people with rosters and off and that type of thing, or called out for...
I don't think any community our size in the world would have 6 for our population. Victor, you know something about this.
Oh, well, they had 5 positions. They were never able to fill the 5th. So they've been operating with 4, with 2 rostered on and 2 rostered off. I've talked to people in the know, and they're quite sure they could do it with less.
Senior nurses, and I'm just passing on the
Well,
message,
I don't
so-
want to say who told me what, but
No, I'm not going to tell you who told me.
there are 4 MRI units, and they're all located in Grace Hospital in our area.
Yep.
The one that was supposed to be installed here was due in November, but probably the instrument's sitting there, or the machine is sitting there, but it's a question of the physical, it needs to be in a special building. So
'Cause it's-
we had a talk at Grey Power by the guy, Sergio something or other.
I think actually, Sheila Russell, I think actually, I'm actually appalled, because I've grown up in a time when probably it was paradise here. We did have these things free. I feel that it's just been apathy. We have let it roll over us, let it happen. And it's time that we, perhaps as a district, need to get back to a bit more caring as we had. At one stage, the Mary Shapley home here, the retirement home, was owned by this district. We supported it. A lot of volunteer work went into there. And suddenly, gone, sold. We need to get back to things like, why are we not fundraising for an MRI machine of our own that's not going to be a private one? Why have we not got the I can never say it right, ophthalmology? We are running backwards and forwards to Tauranga every day. Cars going backwards and forwards, ambulance going backwards and forwards, more money wasted. Why can we not start fundraising locally? And as you say, it may have to come through the council, but why can we not start doing it ourselves? Going out and doing a bit of money rattling.
Back in the day, there was no MRI machine, no such thing. I guess though it was developed in the 80s.
Then,
but anyway, the machine itself is chump change. I mean, it's 1.5 million to $1 million to buy the actual machine, but you do need to have the infrastructure that's around it, and you do need to have the radiologists or the operators of the technicians. So that's two or three permanent staff to keep that machine going.
May I make the comment back?
Yes, it is Bay Radiology, and it is a private outfit. I did object, but
may I make the comment back? You are not going to get any decent staffing here until you get the facilities. You get the facilities, you will get the staff.
you mean the machine? And,
yes.
Yeah, well, you know, when I got here at the beginning of 2019, our hospital, never mind about the MRI, an ultrasound scanner, cardio, right? Biggest killer in this country is cardiovascular disease. And our hospital did not have an ultrasound scanner for cardiology. A machine that's the size of my laptop that cost $5,000, but there was no sonographer either. It came about 6 months after I arrived, so finally we have one there. Still, the waiting time will be long to get a 10-minute scan, but I would say if you're into prevention, then why not have a look at the beating heart and see, you can tell a lot from it, but we didn't even have that in 2019. I mean, it's shocked that I came from Latin America. I mean, it shocked me to find we didn't have an operator and an instrument. Never mind about the MRI at $1.5 million.
I agree. MRI scan, I went through here, had to go to Africa to get an MRI scan. Free. So we do need to do something.
And we're charging twice as much as they do in Argentina in US dollars, converted to US dollars, per scan.
I feel I'm sorry if I'm dominating.
That's all right.
I feel we're needing to get in before there's any more privatisation done. We've got to beat them at their own game. We must get the funding to do it ourselves.
Another data point, we've now got a new X-ray CT scanner in there. The first one, it replaced that one. It's a 2-minute job in and out of the tunnel. The first one was funded by Trust Horizon. So you can crowdfund it.
Good.
I mean, but Trust Horizon is us. It's public money, right?
Kia ora, can I build on what you're saying? So, I think building on what you've said, from my perspective, from what it's worth, take some of it and don't take some of my view, but we've talked today about social determinants of health, how we need to change culture, how we need to increase funding in certain mechanisms or whatnot. I think it'd be really helpful and healthy for Aotearoa to look at what's in our locus of control and accept some of our current realities and what's happening in New Zealand, because some of the changes around culture, management, decentralisation, centralisation, that unfortunately they're not new themes. And with what's happening at the moment, for example, the data and digital team being restructured, 49% or something of those staff are being culled. This is stuff that I think would be really healthy for us to accept that it's happening. No, we don't like it, but actually refocus our energy on of what's in our locus of control. So by that I mean, I think Ian made the comment that we, as a nation, we plan to the hilt. I'm a health planner, and the amount of strategic plans I've seen without measurable actual KPIs or things that we actually measure. There's a plan, but we don't, and we sometimes implement, but we don't monitor. Post-occupancy evaluations in hospitals, for example, are only just becoming mandatory in New Zealand. Now that should have been done yonks ago, to go, right, what are we actually, is what we're doing actually working? Are these hospitals and health facilities actually hitting the mark? And if not, because it is a complex problem, not a complicated problem, we need to keep tweaking and amending. So I feel like we've got this national, however it's come about, but this analysis paralysis, and we put strategic plans in, but we don't actually measure and tweak. So coming back to, I think would be really healthy for us to go, all right, what can we do in our community? We know that electronic medical records are never going to be a thing nationally for the next few years because they've just cut all the funding for sound digital infrastructure. But what can we do that's really going to help a difference for us? And start small and implement and monitor and just get our confidence around doing and acting and tweaking. And we're not going to get 100% perfect, but if we get started and tweak, then I think that's going to be healthy for us, coupled with our collective mindset of what we need to do at a national level.
Rachel, could you maybe introduce yourself and tell us what area you've been working in?
Kia ora.
Or for the others, anyway.
Ko Rachel Morris taku ingoa, ko Ngāti Raukawa te iwi, ko Ngāti Mahana te hapu, ko Hautiri te maunga, ko Ora Kanui te awa, ko Whakara te mai te marae. Engari no whakatāne au. I'm Rachel, I'm born and bred in Edgecombe, and I have had a few different health hats over the years. I started off as a radiotherapist and worked in the UK and Australia in radiotherapy, and then went into working on digital hospital project teams, so working with the design consultants in PPPs actually, and then being the liaison between the consortium and the state or the clinical staff to make sure that the infrastructure actually reflected their models of care and how they wanted to work. And then I brought my skills home. I wanted to come home to New Zealand, so I was in project management for the Dunedin Hospital for a few years. And then when I was pregnant with my first child, we moved home because my partner's parents live in Hopi and mine are still in Edgecombe. And I'm also a kinesiologist, so that's more of an energy modality. And we've been here in Whakatane about 3 years, and I'm due with my next baby in 3.5 weeks. Well, with my second baby, I should say, not my next. But yeah, I've got a real passion about trying to help in practical ways without. I find myself getting overwhelmed I think it's that balance between what can we actually do locally and then what's kind of a bit more nebulous. Yeah, thanks.
Does anybody understand on what basis 64 IT people were culled when we just heard that we're still using fax machines and our IT systems are in a shocking state? In fact, I would have thought, wasn't there a couple of years ago that Waikato Hospital also had a cyber attack or something, and it was a close call. So how does whoever the decision makers are, on what basis do they just come in and do that? Because I don't get it, but then I haven't looked into it in any detail.
Victor, just to add to
Victor,
that.
can I?
Oh, sorry. Sorry. Ian? You want to say something?
You go.
Okay. Just to add a little bit to that, I have no idea why those decisions are being made other than I think it's just in the interest of saving money. I do know, or had been told from fairly good authority, that regional hospitals around the country, which will include Whakatane, as well as Mid-Central, have a cap, if you like, a ceiling of how much expenditure they can do around procurement, and I think it's 100k. And my understanding is that all decisions over and above that then go to head office, and they've been very reluctant to spend that type of money. But Ian may have more insight into that than myself or Terry.
There's not much. Well, there's a complete absence of science or methodology in terms of the IT cuts, other than that they are to meet a budget requirement, and they're very arbitrary. The problem, it's pretty much a slash and burn approach that's been taken across a lot of the unseen work, but dependent work that's actually done in the system. That was a point I was trying to make earlier. I think it's so if you're going to actually look at the positions that you have before you start making decisions about disestablishing positions and which ones, you need to look at the functions first, and then look at whether the function is fit for purpose or not, or whether it needs to be modified or is unnecessary. That did not happen at all in the IT cuts. I just mentioned as well that someone referred to earlier to the importance of an electronic medical patient record nationally. And there was a lot of work done on that in the late 2000s and early 2010s. And the DHBs were collaborating on doing that. And then it was taken out of their hands and pushed up centrally. And there was a couple of other changes at the central level as well, which kept, they created a structure to do it, and then they disestablished that structure to do it nationally. And so nothing happened. So what happened behind the scenes is that the 5 DHBs in the South Island actually got together and developed their own electronic patient record for the South Island DHBs. And for reasons that completely escape me, it was never picked up on, and so let's learn from this nationally, and how do we adapt that or convert it into a national accessible record, because it makes the world of difference in terms of the efficiency and the effectiveness of what specialists and nurses actually do. The problem has been at the central government level, disruptive, not listening, and remote.
Exactly.
Well, Yeah, I guess I'm just
Yes.
wondering who actually makes the decision.
Yeah.
Is it the minister? Because I'm sorry, but the minister, how would he know what's going on? Somebody below him has got to be saying, "Oh, well, this is what should go." And even if, I mean, hard to believe it's totally arbitrary, but it seems that way.
All of these decisions ultimately obviously rest with the minister, but in terms of delegations, it's essentially now the commissioner. Previously, it was the Board of Health New Zealand, and now it's the single commissioner. And although he does have some deputies, but they're just too preoccupied with other things, and the quality of leadership is not great. And the fact that they're prepared to, arbitrarily cut out staffing levels for IT is indicative of a wider problem. But if that doesn't give a message about the poor quality leadership, then I don't know what does.
Yeah, well, our commissioner did manage to score a victory with getting Milo reinstituted in the staff rooms, didn't he? That was a big win.
Oh yes. I almost stood outside Health New Zealand with a placard saying, "Well done, you've saved Milo."
Yep, save Milo. Malcolm, you were going to say something? Oh, no, okay.
No.
Prue.
Just a slight change of subject. The talk from Robin Gauld on the private health insurance side of things, when he said it could be run by something like ACC, I thought, no way. I mean, ACC now is not working well. It's ageist. If you're over 60 and you have to have you have an accident and you have a scan done or an X-ray or something, and it shows up a bit of you might have a fracture, but they see a bit of arthritis and it's caused by arthritis. And whether it goes to review and then to anything else, it goes to arbitration or mediation. No, wouldn't accept it. I had a broken hip for 18 months. I was on crutches till I had to get it done through the public system. And imagine if that's primary health care. It would be shocking. Sorry, you're over 60, heart complaint. Yeah, we're not spending money on you. No way. That I think privatisation of our primary health services would be. You think people, it's it's not a level playing field now. It would be really bad if you're poor or old. There's no use for you.
I guess what Robin was getting at more, my interpretation of it was that we use the machinery of ACC without actually being the same as ACC. Yes. ACC was about accidents, so...
Yes,
I mean, I pay quite a bit. My bill was like $3,800. I've never claimed anything because you've got to have an accident. But the Japanese system was cited. That's an insurance-based, public insurance-based system where everybody pays in. If you've got the means to do it.
Well, that's what our taxes are for.
Yeah, that's right.
Really, that's what our taxes are for. We've paid it all our lives. We get a bit older and you can't afford health, because even if you pay all your life while you're earning high, and then you get older and now all the premiums, you're going to cost a bit. So your premiums go up because of that, because you're not on a level, again, it's not a per capita type thing. I absolutely promise you, because I always thought, I don't need accident insurance, there's ACC. You get hit by a car and then suddenly they go, oh no, we see a little bit of arthritis, not in that hip, in the other one. Yeah. And you're just shoveled off into oblivion, they don't care.
Would it be possible if you'd been to another ACC?
I got a lawyer. It went to mediation.
Would you have, they could have passed you? You know, there's some people that are...
Well, it went higher up because it went to mediation. It was the ACC lady. I got a lawyer, and it was during COVID, of course, so it was all done on Zoom. 18 months on crutches. I couldn't work. They wouldn't pay me my wages because I had to knock off work because I couldn't work on crutches. So I was working in community mental health, and it wasn't felt that it was I was safe on crutches. So, so anyway.
Andrew?
I don't see it as a thing.
Thank you. Just referring back to a comment that was made earlier by one of the people in the public gallery, I'm surprised too that the room wasn't full of people. Not only does it involve the younger generation with regards to gynecology, etc., it involves the older people like myself. And I think Sheila hit on the nail on the head when she said, I think we still do live in paradise. But I would just reiterate, going back to myself as a younger fella, while I was earning, I had private health insurance. And again, as has been pointed out, by the age of 65, the premiums were going through the roof. So you make the decision, can I afford it? And I can honestly say, no, I could not afford it. Again, having been diagnosed as a type 2 diabetic some 15 odd years ago, I again was under a regular doctor through the Copio Medical Centre. My doctor resigned last year. There's been no replacement of doctor there now. I do get my 3 monthly blood tests, and I get to see a diabetic nurse. But other than that, if there's anything else, I was shown the room where you go and you sit before a screen, you have a virtual appointment, which again is something that I thought, wow, that's third world stuff. I wouldn't have expected to see that here in Whakatane. Again, I was under the podiatrist at the hospital. The last podiatrist, Heidi, went on maternity leave. While she was on maternity leave, they brought down a podiatrist from Tauranga, and I knew damn well the first time I met with him, he was going to sign you off and say, look, any further treatments, you can undergo through a local private practice, the podiatry in Whakatane. When I challenged that, being an amputee and, care of toenails, especially with a diabetic, at paramount, you don't get any infections in there. And then I was given the choice of having every second appointment would be through the hospital. But again, it's a service that, okay, we've got a follow-up service of sorts. I've been really interested today to hear the speakers across all the various topics that we've covered today, and I can relate to so much of it, as I'm sure a lot of you people can as well. And while I really appreciate that it is not core business of council, I do also agree with the speaker here that was talking about the Kapiti, and I know Kapiti have got an advisory service which apparently is not funded or costed to ratepayers. So I would certainly support something like that happening within the Whakatane district. And I'm pretty sure that, it would get a pretty wide support because, again, living in a rural community and being affected by transport and accessibility issues, I'm sure that we could be looking at something that would really help to align the fares that we have. Just going on, again, the fact that Tauranga, Rotorua or whatever appear to be the hospital that we were sent to in the case of a real emergency. I'd like to think that we can give some sort of security to our residents that we have got a service, or we can advocate on their behalf to make sure that we get these services as much as possible into Whakatane again. Kia ora.
Thank you, Andrew. Sheila.
I'm a great one on letting people know, educating them. I'd like to knock down these walls today. I wish this had been the centre of the town square, so that the people outside could have heard this. Yeah. I know that you've been given the chance, but not all of them can take it. Interesting to see that a 6 o'clock meeting the other night was packed. I feel that we need to get the message out that privatisation is not the glorious thing you think it is. In my family, two visits to private hospitals, both ended in disaster, and both being told, well, you can go back to the public service and get it fixed. Not good enough. We need to let the people know in our district, we can't do much more, and thank you to these people for taking it further, but we need to let the people locally know that our privatisation is not what is they think it is. Maybe a lovely hospital room, but they don't have the facilities that public hospitals do. We need to let them know that if anything goes wrong, they've got no backup. We need to let the people know that things have become as bad as you say. If women can't get hysterectomies when they need it, we're going to have unwanted children. It just goes on. We've got to let people know how bad the system has become. I'm appalled.
Well, you're part of Grey Power that we've been advocating for
U3A,
years.
we should be taking it around these
U3A was invited, all 250 members.
Yep.
But, well, this is it. Grey Power Federation level, when we put a remit on the table advocating for, calling for a halt to ongoing privatisation without good evidence, it didn't make it anywhere, and yet they've got it on their website today. So I'm a bit annoyed with them. But yeah, I mean, look, we've actually done quite a reasonable job, I think, of getting the word out there. But people probably think it's a virtual conference. I can jump online and I can hear it all at my leisure, which is, I mean, some of you already know that if you're in this room, you can hear. It's harder to hear in this room than it is on your computer sitting at home. So, yeah, the sound is better at home. So maybe they've decided just to watch it from home. But our politicians have been advised, various news media, isn't that right, Kay? What news media was advised? I mean, RNZ, you name it, yeah, so, you know, they like sensational stuff. They don't like...
Yes.
You know, they need to get in and actually do some investigation, which is hard work. I mean, I've done it. Those numbers I put up weren't easy to get. They took me years to put together. Where's our news media doing any real serious investigation? I'd like to see it. But anyway, maybe I'm being unfair to them. They want sensation.
Yeah, investigative reporters have all been sacked.
That's right.
I'd just like to say there is one political party here today. So I'm the health spokesperson for Outdoors Party.
Oh, good on you.
And we would totally talk about what
Good on you. Yes, Sue.
As a layperson, and I'm not pregnant and I don't need a hysterectomy, but I'd like to just say thank you very much to Dr. Luca for the time he's put into organising this in his own time as a very important forum which needs national recognition, and I hope that it can be, thank you also to Council for facilitating it, although I see that there are only 2 councillors who've shown any interest in it, apart from the Mayor. Which seems to indicate not much interest in health.
They could be online. They could be online.
Yeah. And I was going to say that I think it's a heck of a good idea if there's a bit more publicity given to how on earth to access this. We need a link or something for people who are as ignorant as I am, which is probably 50% of the population, in order to actually access this, because I want to go home, for instance, straight away and watch the whole thing again, because I glaze over with figures, and there are a lot of people around like me.
Fair enough, Sue. Good comments.
Don't you dare wrap it up.
I'll just let you know that in order to see the video, you jump on Whakatane District Council's YouTube channel, and it should be there in full view of everyone, and press the button and it should go. It wasn't working, the link, earlier on, I think, but it is now.
Yes, I'd just like to say, Anne Kibble is my name. I'd just like to comment on the fact that our new Prime Minister, Christopher Luxon, seems to be completely uninterested in the health system. That's my opinion. He's not helping. Dunedin needs a new hospital. Other places need upgrading, and there's, no, haven't got money for this, haven't got money for that. And then I've just learned just recently that he's going to give 45 million to Mr. Zelensky, for the war effort. And I thought, well, we've only got 5 million in population in New Zealand. I mean, I know that that they need help with the war. Mr. Zelensky does, but I feel that we need help with our health system too, and that's in the 60s and 70s when I was nursing, it was in a very good state. The health system was wonderful. You didn't have to wait, weeks or months for an appointment or for an operation, and like you do these days. And I think that we should badger Christopher Luxon to sort of worry about the health system in New Zealand, because it's far from good anymore. So what can we do? I know that Victor Luca does help through Grey Power, and that's wonderful. He's been great in being the president of Grey Power, and he's working through the health system through Grey Power. But I don't know what we can do to badger the Prime Minister to do more.
Perhaps send him an email and just put with the YouTube link on it.
Yeah, well, why don't we? Well, I'd be happy to do that, because I think he's such a businessman. He wants to get the country back to financial stability, but you can't do that in one term. It's got to be done gradually, and I think it's very important that we've got a good health system, because if we haven't got a good health system and workers get sick and injured, we're not going to have people in work either. And so many people, cancer's a real worry in this country. There are so many people with cancer and not being able to get operations when they need them. It's disgusting, really.
Can I butt in there, Victor, for a bit? Can I just say a couple of things? I've been listening with intent about, your regional approach and what you need or can and can't do. And if I can use Dunedin as a really good example of what the public can do, I think that's a real indication of the impetus that you can actually do to change indeed government or even any parliamentary policy by sheer weight of numbers and putting together a good argument to put on the table. I think that's really critical. You guys are doing a good job there with Whakatane. I mean, that made all the news here. I mean, we all know about that down here. So you're doing the right thing, but it shouldn't just stop there. You've got other opportunities to get involved, and Malcolm will agree there. These are all interlinked. We're all talking about what Malcolm was talking about in Bulla is happening everywhere. And what I'm talking about is happening in every single hospital in New Zealand. So it's really up to the communities to stand up for the services that they're getting. Instead of putting up, my word is stand up. Because if you're not getting what you should be getting, there's a problem. It's dysfunctional. We know it's not working like it used to. But if no one complains about it or does anything about it, guess what? You will get more of the same. When it starts to affect politicians, as much as I hate to talk like this, politicians ultimately do decide the future makeup of what's going on in our everyday health system. When they see the polls go down because of policy decisions they're making, and you are vocal about it, things will start to change. Now, you might have seen the polls lately, and we're seeing what's happening. And I think we've got a real opportunity to get involved. And I think the work, the best thing that's happened to me, to be honest, is getting on board with a lot of the patient advocates. I think as health professionals and professional leaders, we've tended to operate on our own and away from everyone else. And now we've started to connect the health system to the patient advocates so that we can all be in this together to show that we've got solidarity. And yes, we actually know by being on the inside what the problems are and often what the solutions are. So yes, there's a few learnings here. You can moan and stand and do that, but you've also got to think about what is the way out, what are the solutions for that. And it was really interesting to hear about the health planning side of it. I think that's critical. I bring up a couple of things here, like national screening programs. Absolutely essential for us for early detection to stop unintended consequences further down the line. We are simply, as a pathology sector, until we've got national control of all of our services, we are realistically pretty much unable to do that. And because of the capped budgets, we can't fund it. So we can't screen for PSA, for example, for prostate cancer, like the Australians do, like they do everywhere else in the world, among many other screening tests that we should be offering in this country. We have the national cervical screening, but that's actually run completely separately from the pathology system. Ultimately, in the future, the bowel screening as well, they all should be tied in under the governance, the clinical governance of the pathology sector, so that we can provide equitable access across the country, which is not happening at the moment. So regionally, you have a real opportunity, and let your voices be heard. You, after all, as I said in my talk, too often I think the health system gets caught up in its own importance and forgets what our actual role is and who we are meant to be looking after. Okay, admittedly, if you don't look after your health professionals, it makes it damn difficult for us to look after you, and that's ultimately entwined. But, a forum like this, keep it going, keep the ideas going. If this is happening all over New Zealand, surely that feeling will come out, and I think that's really critical. So, you're doing a great job, and the work that Victor's doing here and getting this all organised, absolutely superb, because the more we get the message out that it's in trouble and get everyone understanding how much trouble it is, surely we can't just let it carry on.
Yeah.
Thank you, Terry. Suzanne.
Following on from that, where is the local press?
I guess they're sitting in their office watching it.
Who's that?
I'm sure.
Videoed.
Oh,
I'm
not only
sure
the
they'll-
local press.
I think we need
Where's
to
Dana
remind... sorry.
Kirkpatrick? Where's Dana Kirkpatrick? Who's the...
She declined the invitation to attend without any explanation, so I can't
We
tell
need to
you.
remind everybody that there is an election coming up.
Well, exactly.
There will be, though.
Yeah, that's right.
Where to from now?
Well, I don't know. We'll see what the fallout is, if there is any. And
You said something just there, why you're looking to make the laboratories be like they were. And I used to travel through every laboratory in New Zealand, and I saw that. And you've never seen a more happy lot of people.
Yeah, in the olden days.
not so happy these days, though, eh? Well, if they're...
It's greed.
Yeah.
Yes, totally.
Basically.
Greed.
Yeah, basically.
Or private.
Victor, I just wonder, though, from a political point of view, whether it is something that we should bring forward to council.
No, I'm actually writing a paper on bringing forward to council a proposal to set up health advisory groups similar to that of Capities.
Oh, you've taken the words right out of my mouth, that's what I'd say. That is what I would like to see you
I've
bring
been trying
forward.
to speak to the Kapiti Mayor for about 3 weeks, but it seems to be hard to get a hold of.
Just going back to the Kapiti Coast, did you actually check with them to see, did they in any way support the
I don't know, but Ian Powell's on the advisory group, so he can answer. Are you still there, Ian?
Good, he'd gone.
Oh.
Probably not. He might have gone. But yeah, I mean, it was a bit fortuitous, really, that I asked Ian because he's been vocal out there in the media, and it turns out that he was on a Kapiti Council advisory group. So I thought, there are terms of reference on their website. There's some quite, there's a bit of information there. And oh, okay. Yeah, and I did invite the Mayor of Kapiti Council to attend this too. In fact, this is the thing that gets me, you can say that, 67 mayors were contacted twice by me.
Oh, yeah.
Before in October, or was it September? And then recently they were sent an invite. So, I guess they're busy, there's council meetings. The Mayor of Kauro has given her apologies. She's in the middle of a council meeting at the moment, so it's...
Started as the first of more.
Yeah, well, the idea was, this is cheap, it costs us nothing. A little bit of Kai there and some help from Kay and my EA. And of course Louise and a few others pitched in, and we've put this together. It's a virtual conference. Doesn't mean nobody's got to fly anywhere or pay for accommodation, but these are the system is complex. You don't get the solutions in one morning. We've put a few things on the table. Positive money, Steve Keen's view of direct government financing of health, which I don't think is impossible. It's actually quite possible, but you've got to understand how the system of money works, and I'm not sure that we do, and I don't think government does either, actually, because if they did, that wouldn't be rolling as they... Well, yeah, well...
Why can't somebody explain to government, do you know you can do this, why doesn't...
Well, that's what Positive Money's going to be doing. They're going to be going there and making their pitch. But yes, look, the Reserve Bank has issued new money in the past, but it funded a property bubble. That's what it funded, to make life impossible for 30 to 40% of New Zealanders. That's what they've done. They engineered a recession, and now we've embarked on austerity, which you just heard from one of the speakers that it actually doesn't work. It never worked. There's no country where austerity has actually functioned. So, I don't know. These are big issues, big problems. But if you don't talk about it and you don't put something on the table, then you're not going to go forward. But this is a start, and we'll see how it all shakes down and then take a future step.
Yeah. Kia ora, can I just suggest that if anybody wants me to email them the direct link through to the YouTube clip, I'll leave a pad at the door and just jot down your email address. Might be easier just to navigate that way, and then if you can then share it with your networks, that would be awesome. Thank you.
And I'd like to thank my compatriot here, not compatriot, actually I'm not Scottish, my Scottish brother over here, who's been pushing for this sort of thing for a while, so we got it done, so thank you to Sandy, and thank you for all of you who turned up to support this today, and hopefully there's others online, but and thank you especially to our speakers as well. But anyway, I'll send them an email thanking them for...
Is there any way of getting, say, a version of this that would be acceptable in schools, high schools? These are the people we're needing to get educated. They're our next voters coming along. They're our next health patients.
Unfortunately, when you're young and healthy, you don't think about health.
But again, Victor, it is something that could come through the Youth Council.
I've been trying to get to the schools to talk about climate change and haven't managed to get that part even done.
But it could be brought through the Youth Council.
Yeah, it could be. The Youth Council should get on board on this sort of thing.
Permission to
All right,
speak.
well, I'll just...
Hold it. Permission to speak.
Yes, permission to speak over here.
This idea about educating young people, and any doubt you've got about young people. Just a minute, ladies. Oh. Any doubt you've got about young people, you should throw them away. The leaders can motivate young people. And I forgot to tell you this in my presentation. I motivated a team of tried high school people. Could you just keep quiet a second, please? I motivated a team of Wakatani trained high school pupils to get fired up about this. I said, you're the ones that are going to get affected most by all these downgrades and changes. And they were really fired up. And what happened next? The school nurse was the wife of one of the change managers, a doctor. Next thing is I went back to the school a few days later and there was silence. So you've got to just motivate them and warn them that somebody might try to, what's the word for it? Try to upset the plan.
Oh.
And yeah, that's what they did, a sneaky disruption. The fact is, you've got to emphasize them that we're living in a nasty world now. That's all.
I've just been informed that Martin Halliday was on this, participated in this, and he's part of Capity Council. He's on Capity Council, and he will be disseminating this to his councillors and the rest of Ian Powell's panel. So, anyway, I'll just conclude with the karakia. Kua mutu o matu mahi mo tēnei wā mana akitia. Mai matu katoa o matu hoa o matu whānau. Ai o ki te aorangi. Thank you very much, everybody. Thanks.